хотел, по крайней мере, на посмотрим.
Если у вас суета еще будет.
Не, ничего, норм. Суета это тоже круто, чем без суеты. У нас уже что, процесс пошел? Так, сейчас, да, наш, да, еще министр спрашивает. О, вот видите, Эбба тоже спонсор, оказывается. У нас вот оно начинается пленарное заседание. Да, зал хорошо, да. Вот этого переводить вообще нельзя. Его не слышно. У него дикция хуже, чем у Кучкарова. А кто он? Я не знаю, но охотно верю.
А где дочь?
Может, у него не было дочерей, кто знает. Может, у него одни сыновья были. Ну, все же бывает. Может, вообще одни сыновья, а дочерей нет, кто его знает. Сейчас герб, флаг, гимн. Вот в этой будке невозможно переводить, вот в таких некомфортно. Давай. Все, норм? Хорошо. Да. Ну, вроде. Я уж не знаю. В тот раз, когда мы это были, помните, знаете, кто пришла? Вот это вот замминистра здравоохранения Басетханова пришла. Она, которая раньше, она вот этот Айоллар Кумитасы, она была, что-то такое было. Я помню, ходили еще туда постоянно. Кто это?
Мурашка.
Ой, да?
Да.
Ой, я уже второй раз ему перевожу, кстати. Да.
Альбертович.
Неважно. Олег, а вы нам на всякий случай тоже можете ссылку эту зумную скинуть? Да, ну нет, сюда, да, вот. Телеграм. Я просто на всякий случай, потому что, может, я ее через наушники бы слушала. Да. Да. Как раз у меня своего богатства достаточно наушников, если что, я через свои буду слушать. Сейчас начнется уже. Сейчас у нас начнется, значит. Your kind attention, please. National anthem of the Republic of Uzbekistan. Олег, ссылку дайте на всякий случай. Если сейчас с наушников не пойдет, чтобы я так села. Good morning, the participants of today's event, dear distinguished guests, dear guests of the Republic of Uzbekistan. It is our pleasure to welcome you at the 50th anniversary of the Republican Specialized Surgery, Scientific and Practical Medical Centers named after academician Vasid Vahidov. Upon your kind permission, we would like to give the floor to Mr. Sherzod Asadov, Press Secretary of the President of Republic of Uzbekistan, for delivering the congratulatory remarks on the behalf of the President of Republic of Uzbekistan, Mr. Mirziyoyev. Good afternoon, dear participants of today's event. Upon your kind permission, I would like to deliver the speech on the behalf of the President of the Republic of Uzbekistan, Mr. Mirziyoyev. Dear guests, dear friends, first of all, I would like to congratulate all of you on the occasion of 50th anniversary of the Republican Specialized Surgery, Scientific and Practical Medical Center named after academician Vahidov. This center is seen as the most reputed research center, which holds its own place in the country and in the healthcare system. And of course, today's event will commemorate the contribution of Mr. Vasid Vahidov, who has significantly contributed to the development of thoracic surgery of Republic of Uzbekistan. And thanks to the efforts of this person, we have been promoting proactively the most advanced methods of healthcare. And as a result of the reforms conducted in the country in the field of healthcare, you can see that we are closely cooperating with the leading research centers all across the world and promoting and implementing and introducing the leading and the most advanced methods of treatment. We have conducted over 200 new types of surgeries which have been introduced to the practice for the first time, and it is very important that we have conducted also around 1,500 kidney transplantation surgeries, and of course you can see that the surgical service all across the country is contributing significantly in this extent. And of course this is the very important factor of development of healthcare, not only in the capital but also in the regions and remote areas. And of course now our people have to travel abroad. They can receive the top quality treatment in their own country. And of course I would like to express my sincere gratitude not only to the doctors and healthcare practitioners, but also nurses and researchers of the center. And we are proactively engaged in modernization and improvement of material and technical base, and so that we will be able to render our possible assistance in all of your endeavors. I would like to wish you strong and solid health and of course successes in your activities. President of Republic of Uzbekistan, Shavkat Mirziyoyev. Thank you so much. And we are now beginning the ceremony of congratulation and award presentation. Upon your kind permission, we now would like to give the floor to Mr. Ismailov Nuriddinjon Muidinxanovich. So now we would like to now deliver the speech on the decree of the President of Republic of Uzbekistan, and we would like to, first of all, regarding the successful completion of surgeries and promoting and strengthening healthy lifestyle all across the country, as well as the professionalism and expertise and contribution in training. Here will be the awards conferred to the following. First of all, we would like to congratulate Mr. Ismailov Said Murad Ibrahimovich, Director of the Republican Specialized Surgery Scientific and Practical Medical Center. And the second degree, the Order on Healthcare to Mr. Gholamjon Zahidovich, Head of Thoracic and Abdominal Oncosurgery Department of Republican Surgical Scientific and Practical Center. Doctor of the Thoracic Abdominal Surgery Department of Fergana Province, Haydbulina Zarina Ruslanovna. Head of Department of Clinical Biochemistry and Microbiology of the Center after Vahidov, named after Vahidov, Haydarov Alisher Erkinovich. Head of Department of Cardioanesthesiology of the Center of Vahidov, Yarbekov Rustam. Head of Department of the Center of Vahidov, Order of Duslik, Friendship, Rustamova Farangis Kamranovna. Medical fellow of the polyclinics under the Center of named after academician Vahidov. Шуваева Ольга Владимировна. Head of Medical Archives of the Center of academician Vahidov. Medal for healthy lifestyle, Juraeva, Miss Juraeva. Head of MRI and CT Department of the Center named after academician Vahidov. Kadyrov Marat Jalgasovich. Doctor of the Surgery Department of the Center, the affiliate of Center of Vahidov in Republic of Karakalka, Pakistan. President of Republic of Uzbekistan, Shavkat Mirziyoyev. And you can see that we had persons who have been awarded, and now we would like to give the floor to one of the person to whom the award have been confirmed, to Madame Haibulina, head of clinical biochemistry department of the center named after academician Vahidov. Dear guests, dear colleagues, today is a very, I would say, remarkable day for all of us, and it is an honor for us to receive such award. It's not just an honor. I guess this is acknowledgement and recognition of the merits of all of our team, from the leader of our country. Development of lab medicine becomes very, very important, and of course it is challenging us not only in terms of our professional growth, but also to the technologies which we are using. And of course without support of the President of Republic of Uzbekistan, we would have never reached these results, and the funds which are channeled for development of healthcare, for international cooperation, and a special attention which is paid by the President of Republic of Uzbekistan, as well as the surgery service and transplantology, especially after the presidential decree of 2021 for development of transplantology. We are experiencing qualitatively brand new growth, I would say, and previously the only thing we could render is just clinical research, but now we can do a complete check-up not only of recipients but also of donors, including genetic research and genetic tests. Availing myself of the opportunity, I would like to congratulate all of our team for their support, and we are very thankful to the President of Republic of Uzbekistan for his trust. This trust, of course, calls us to keep our heads high and continue of the work of our seniors in this extent. Thank you so much for your kind attention. And also now we would like to give the floor among of our awardees to the director of the center named after academician Vahidov, to Ismailov Said Murad Ibrahimovich. Please, sir, floor is yours. Good afternoon, dear colleagues, dear friends, dear guests and participants of today's event. For us and for all of the healthcare practitioners of Republic of Uzbekistan, it's a great holiday because for us especially it's a double holiday, double anniversary, I would say, because it is coincides with the 50th anniversaries, 50 years long pass of our center. Of course, it's a historical experience, and of course there's no need to mention the contribution of academician Vahidov, and all of us have been commemorating him, and our president actually he came with initiative to have the monument of the academician Vahidov over here, and actually we are very thankful for the congratulatory remarks of the president, and we are very thankful for all of this. And once again, also I would like to mention that His Excellency President approved his decree to award our team members. And of course, we are very happy because this is the recognition of the contribution not only of our center, but of 2,000 of surgeons who are working all across the country, and we feel this recognition. And all of you have heard the presidential congratulatory remarks, and of course it is very touching, and all of us are well aware that our president has just one requirement, that we need to diversify high tech which we are using, as well as the types of diagnostics which we are providing, alongside with improving the skills of our specialists and practitioners who are working in remote areas, and so that we will not create an issue for patients, making them travel from certain regions and provinces to Tashkent to obtain high quality treatment. I guess that altogether we need to meet the requirements set by our president, so technologies will be equal not only in capital city Tashkent, but also in major cities, as well as in all the districts all across the country, since our president is recognized us in such a manner. It makes us in a situation to double our efforts, and actually today I was also awarded, and I guess these merits symbolizes the presidential trust, and of course some sort of advance payment for us to, I would say, work hard in progress for the future. Once again, thank you so much, and my congratulations. Upon your kind permission, we would like to give the floor to the Minister of Health Care of Republic of Uzbekistan, Mr. Khudayarov Asilbek. Please, sir, floor is yours. Good afternoon once again, dear colleagues and dear guests. We are very thankful to have all of you here at the 50th anniversary of Republican specialized center, surgery center named after academician Vahidov. We have guests from Kazakhstan, Tajikistan, US, Germany, and other countries from all across the world. And we would like to express our sincere gratitude to all of you, dear guests, who came here from other countries to be here to join us. And I'm pretty sure that today's event will help us to promote mutual cooperation and win-win exchange in experience and expertise, and will serve a good platform for scientific endeavors. And all of us have heard with great satisfaction the presidential congratulatory remarks, and of course you have seen that on the basis of the presidential decree, several healthcare practitioners have been awarded with signs of merit, and this is some sort of symbolization of the presidential attention paid to the healthcare sector, as well as to the improvement of quality of life of people. And of course it should be a stimulus for us, incentive for us to work in progress for our citizens, for our people. And healthcare is one of the top priorities of the government policy, and the presidential requirement is for doctors and for the healthcare, good quality healthcare services, to be as closer to people as possible. And of course we need to render high quality, top quality medical and healthcare services to people even in remote area, notwithstanding where people are. Therefore, the government is especially keen on developing and modernizing material and technical basis and the equipment of the research centers, as well as the government is proactively promoting the development of minimal invasive surgeries, not only in the capital in Tashkent but also in the provinces and regions. Of course, we need to pay attention to the development of human resources. Of course, it is not easy to, I would say, to have the teams, high quality professionals in all of the centers. Therefore, the government is especially focused in nurturing human resources, and I'm pretty sure that the healthcare sector of Republic of Uzbekistan will be developing sustainably in coming years. Once again, congratulating you on the 50th anniversary of the center named after academician Vahidov. We would like to wish you solid health and successes in all of your endeavors. And now on conferring the award of the outstanding healthcare practitioner for strengthening international cooperation and promoting cooperation between surgeons of Republic of Uzbekistan and other countries, as well as development of high-tech surgical assistance, as well as on the occasion of 50th anniversary of the center named after academician Vahidov. Congratulate with the badge outstanding healthcare practitioner 2. Barkhanov Vladimir Alexeyevich, the principal of Achakovsky Clinical Hospital, number 1, Krasnodar District, Russia. And Leo Bakeria, president of National Cardiovascular Center named after Baskulev, as well as Shevchenko Yuri Leonidovich, president of National Surgical Center named after Pirogov. And unfortunately, since these two guests are not here with us, the award will be conferred to them, handed over to them a bit later. And for the contribution of development of the healthcare sector of Republic of Uzbekistan, as well as on the occasion of 50th anniversary of the center of academician Vahidov, Mr. Ligay Ruslan Yefimovich. Senior medical doctor of the center named after academician Vahidov. Tursunov Nasriddin Tashevich. Head of thoracic surgery department of the center named after academician Vahidov. Buronov Khayrullo Jumabayevich. Head of cardiosurgery department of the center named after academician Vahidov. Nazarova Елена Владимировна. Head of CT and MRI department of the center named after academician Vahidov. Gani Hadjaev Saidin Hoджия Sadырович. Head of Consultation Polyclinics Department under the Center of Academician Vahidov. Sultanov Alisher Tahirovich. X-ray doctor of the Center of Academician Vahidov. Jalilova Aziza. Senior nurse of the consultative polyclinics under the center named after academician Vahidov. Khalmurzin Shuhrat. Head of HR department of the center named after academician Vahidov. Mahmudov Akmal. Chief engineer of the center named after academician Vahidov. Khalmatov Farhad. Chief accountant of the center named after academician Vahidov. Minister of Healthcare of Republic of Uzbekistan, Mr. Aslidin Khudayarov. Dear guests, dear friends, and here we had our congratulate persons, awarded person, and now we would like to give the floor the dear participants who have been awarded with degrees. We would like to give the floor to academician Parkhanov Vladimir Alexeyevich, who is the chief medical doctor of the Achakov Clinical Hospital, Krasnodar, Russia. Dear colleagues, I am very thankful for the award which was confirmed. Actually, I was working here, I was working in Russia. I like Uzbekistan, I like Uzbek people, and of course we are doing everything for people to live a good quality life. We are learning from you, you are learning from us, and we are going to continue this work. Please stay in solid health and be happy. In this center, which I have seen so many years ago, I can tell you that people are here growing professionally, developing professionally. Previously, you have been a lot of surgeries on echinococcus, but now you are doing the surgeries for stenosis of trachea. You are doing the liver and kidney transplantation, the complex surgeries on heart, especially in children. So this center is the most advanced center in Central Asian region, and you are doing everything in brilliant manner, in excellent manner, and I am very happy to see your successes. I am very thankful to the president of both of our countries. Thank you so much for your kind attention. And now we would like to give the floor to academician Baymakhanov Balatbek, Director of National Surgery Center named after Tsikhinov, Republic of Kazakhstan. First of all, I can tell you, dear friends, dear guests, that since we are gathered here at the 50th anniversary of the Republic Center named after academician Vahidov, and I would like to congratulate you not only on my own behalf, but also on behalf of my colleagues and of all the practitioners of the healthcare of Republic of Kazakhstan. Please kindly stay in solid health and I would like to also thank the steering committee to invite me to participate in this event, and for me it's a great honor, and I can tell you that our bilateral ties within these 50 years they have already been they have been founded and they have been established by our teachers, our seniors, our mentors, Mr. Wahidov, and of course our senior academician Tsikhinov, they have been very close friends. They had, I would say, been in contact on daily basis. They have been meeting regularly to share their achievements and results, and we are now very happy to see the achievements in the field of surgery. And the Center of Surgery of Academician Wahidov is the leader not only, I would say, in practical point of view, but also even in theoretical fundamental research in Central Asian region, and there are a lot of evidence to this. We can tell you that the level of development of surgery is determined by the level of development of high-tech surgery, especially in such a domain as transplantology, especially if you are doing such a complicated surgery, complex surgery as transplantation from the relative donor. And I can tell you that you will be the leaders in future, not only all across Uzbekistan, but in the whole Central Asian region. I would like to wish you successes once again. Thank you so much for your kind attention. Yes, indeed. Thank you so much. And dear friends, we would like to give the floor to Mr. Ashrafi Ahmad Shah, the head of cardiothoracic surgery of the Hospital of University of British Columbia, Canada. Dear colleagues, please kindly be advised that simultaneous translation is rendered. Добрый день, дорогие друзья. Добро пожаловать на эту замечательную конференцию. Меня зовут Ашрафи Ахмад Шах. Я заведующий отделением кардиоторакальной хирургии больницы Университета Британской Колумбии, Канада. И я, конечно, хотела бы сказать, что это мой третий визит в Республику Узбекистан. И даже за вот этот короткий период, каждый раз, когда я сюда приезжаю, я узнаю, что и вижу, понимаю для себя, что в Узбекистане происходит значительные улучшения, и действительно идет. Я с энтузиазмом наблюдаю, насколько хорошо развивается хирургическая служба в стране. Я действительно впечатлен тем лидерством, которое господин Саид Мурат, Улугбек, Руслан, как они действительно работают над улучшением работы центра, над улучшением и совершенствованием службы для пациентов, для населения. Они действительно привержены. Это замечательный центр, это превосходный центр, уровень знаний, уровень операций, которые здесь проводятся, они соответствуют самым высоким международным стандартам, и я впечатлен именно также и квалификацией наших хирургов. Вы знаете, в прошлом году конференция проходила в Самарканде, и она была очень хорошо организована, эта конференция, и в этом году я очень рад видеть, что хирурги со всего Узбекистана и со всего региона, они собираются здесь для того, чтобы действительно оттачивать свои знания, обмениваться навыками, экспертизой и опытом. И я надеюсь, что Узбекистан обязательно в региональном разрезе обязательно станет лидером. И людям не нужно будет выезжать в зарубежные страны, в дальние зарубежья, чтобы получить качественную медицинскую помощь. Я думаю, что это время уже не за горами, потому что мы видим, что действительно уровень развития, он очень хорошо продвигается, повышается уровень медицинской помощи, заботы, он чувствуется. Я еще раз поблагодарить вас хочу за приглашение и за всю вашу замечательную работу, и надеюсь, что конференция будет успешной. Спасибо большое. Да, действительно, большое спасибо за вашу вдохновляющую речь. Dear friends, dear participants of today's event, I would like to kindly draw your attention to the screen, and we will play you a short video presentation about the center, please. You can see that indeed we are having here thoracic and abdominal surgery as well as cardiovascular surgery department, and the center performing the transplantology surgeries from the live donor in kidney and liver. The center is one of the leading medical entities in rendering high quality medical assistance. We have performed over 40 liver and over 50 kidney transplantation surgeries and become the leading medical or institution in this extent all across the country. Center is proactively cooperating with over 40 of the leading medical institutions all across the world. Dear participants of today's solemn events, you are very well aware that we have planned to have also plenary sections within the framework of our today's event. Now we will go for 5 minutes break, and after this we will proceed and we will meet in this meeting room.
Собирай.
Today's event. Please kindly your attention to the screen. The congratulatory remark by the Ministry of Health of Republic of Russian Federation. Dear colleagues, dear guests, it is my pleasure to welcome all of you at the Vahidov Readings 2024. Academician Vahidov, he was the the person of Science of Republic of Uzbekistan who has significantly contributed to the development of diagnostic, transplantation and thoracic surgery, including even the laser ultrasound, so the most advanced methods. And of course, he has established long-term professional connections with the surgeons from all over the world. And for our mutual cooperation, it is very important to have
Нет, нет.
course, they are keeping up with the recent trends, and of course, they are keeping up with the recent trends and trying to implement them in their practice. And we are also promoting the healthcare practitioners and healthcare communities cooperation. I would like to wish you more successes in your endeavors as well as interesting discoveries ahead. Thank you so much for your kind attention. And now, upon your kind permission, and now we would like to give the floor to the Mr. Amiran Revishvili, Director of the National Surgery Scientific and Research Center named after Vishnevsky. Dear colleagues, dear guests, dear friends, upon your kind permission, I would like to congratulate you on the occasion of 50th anniversary of the center named after academician Vahidov. And unfortunately, I cannot be physically with you, but I'm joining you offline. And I am very happy that this center is celebrating its 50th anniversary. Previously, it was a Tashkent subsidiary of which was specialized on clinical research. And then it was transformed into the Republican Research Center specialized on thoracic surgery and practical medical assistant. And you can see that we are working on resolving the professional issues. And we are also promoting human-to-human relations between the specialists of our centers. And of course, our center is also trying to contribute in development of our scientific cooperation, and we are ready to stand by you with our colleagues. And we are also trying to streamline cooperation between our Uzbek counterparts and colleagues from all across Russia. And of course, the center is gaining international recognition and closely cooperating with leading international medical centers. And we are well aware that the thoracic surgery is one of very complicated, I would say, domains in surgery and diagnostic, especially in kidney, especially in liver. All of them are not easy to be performed, and I would like to congratulate you cordially. And at the moment, we would like to give the floor to the president of Chedzyan University Clinics, Professor Van Weylin. Дорогие друзья, я являюсь президентом второй специализированной университетской клиники Чжэцзян Китайской Народной Республики. От лица тысячи наших сотрудников, специализирующихся на торакальной хирургии, я хотел бы поздравить от всего сердца сотрудников Национального исследовательского центра имени академика Вахидова. Для меня большая честь присутствовать здесь с вами, хотя и в онлайн-формате. Я также очень рад того, что 7 человек от вас, 7 врачей приняли участие в наших программах сотрудничества. И я хотел бы пожелать вашему учреждению продолжать играть ведущую роль в обеспечении здоровья людей, укрепления здоровья, а также внесение все более и более активного вклада в обмены между специалистами сферы здравоохранения наших стран. And now we would like to give the floor to Professor Oleg Akbarov, Director of Department of Cardiothoracic Surgery of Karamont. Dear colleagues, my cooperation with the Center of Academician Vahidov started quite long time ago, and now I am with all of my pleasure enjoying the development of thoracic surgery in Uzbekistan, and this clinic is perfectly equipped. I mean, technical equipment is improving as time goes by, as well as the expertise and, of course, the craftsmanship, I would say, of the surgeon is also growing, and the surgeries are showing a very nice success rate. And I guess my cooperation with the center named after academician Wahidov started with my participation at one conference, and still it is going on. We are not going to stop it, and we are planning to renew the program of training of young healthcare practitioners in our clinics so that you will get the best results. And it is my pleasure to always to come to Uzbekistan. Whenever I'm here, I am following the successes of the leading medical institutions here in Uzbekistan, both in clinical and practical activities. Thank you so much. And now, according to our program, we would like to give the floor to the speeches. So we would like to, first of all, call on stage academician Baymakhanov and academician Parkhanov. Please kindly take your seats, and we will start our panel session. Please. Our moderator will be here with us, Mr. Ismail Said Murad. Dear gentlemen, kindly take your seats.
Проверь сначала его.
Проверь кликер. Вперед назад, чтобы работал.
Ты ему сейчас отправь, презентух отправь, здесь. Запорги. Запорги.
So, upon your kind permission, we will start our agenda. We will be discussing now the transplantation of the liver from a live donor. We will have several authors actually here, but anyway, we would like to give the floor to Mr. Babajan because it was indeed a big team of authors who came up with this session. Good afternoon, dear colleagues. It is my pleasure to be here to open up the scientific part, I would say the plenary session of today's event. And upon your kind permission, I would like to probably focus on the most important issue of today's of the surgeries nowadays, and share our experience experience in transplanting liver from a live donor. Talking about epidemiology of liver cirrhosis, we can tell you that these epidemiological aspects, I mean, if we will, of course, learn more about this, the mortality rate has dropped from 21% to 100,000 of population, and it drastically reduced. That mortality ratio is reducing, but please kindly look at the indicators. We are getting more and more patients, including the patients with decompensated liver cirrhosis, and of course we are experiencing also the significant growth of patients also with compensated cirrhosis. So if you will pay attention to the screen on the etiology of liver cirrhosis, of course the leading disease, leading reason for this is alcohol, then is hepatitis C, and then hepatitis B. And in Uzbekistan, we have a high endemicity rate for hepatitis B delta. And among Central Asian countries, Uzbekistan ranks, I would say, in the leading positions in terms of mortality from liver cirrhosis, according to the research published in Lancet Research. You can see that mortality rate was 11,000 per 100,000 of population. So this is the highest actually number in Central Asia, and even globally Uzbekistan is among the countries with the highest rate of mortality, which is 50,000 among for 100,000 of population. Therefore, thanks to the thanks to the temporary regulation approved by the Cabinet of Ministers of Republic of Uzbekistan, we had the first surgery on a liver transplantation implemented, and we are working according to the law of the Republic of Uzbekistan, which was approved on 11th of May 2022 on transplantation of organs from live donor. And today is our experience is around 111 surgeries in kidney transplantation and over 1,400 of surgeries for kidney transplantation. We are proactively cooperating with the Center of Academician Shumakov, the Center of Minsk, Belarus, as well as the Center of Achakovsky, and we're closely cooperating with Indian colleagues from Hyderabad, India, and of course we are very thankful to our, I would say, senior scholars like academician Gatsiye, academician Parkhanov, with whom we are proactively cooperating both in scientific and in practical domains. So talking about kidney transplantation, we have selected our surgeries. We have divided them into two periods. I mean, this 111 liver, the transplantation surgery. So the introduction period since February 2018 till June 2023, we had 59 surgeries, and development stage started in June 2023, which is ongoing. We have conducted 52 transplantations from relative donors, and what has I would say impacted the change of paradigm is administrative support. It's a result of professional training in the leading centers all across the world, and the major criteria is that the government helped us with standardization of the national protocol of teaching and of conducting surgeries, as well as providing the drugs in the region, I would say immunosuppressive drugs, as well as our improvement in terms of tactical approaches to anesthesiology, and of course improvement of resection stages in donor, as well as hepatoectomy in recipient, as well as improvement of hemostasis system, especially stabilization of local hemostasis, as well as improving the techniques of arterial and biliary transplantation. And this surgery is very complicated. I mean, the liver transplantation surgery. And if you will look at the etiology of liver disease, you can see that 90% of patients are patients with hepatitis B delta, which leads to cirrhosis. Median age is 40 years, plus minus 15 years, and you can see that the degree of severity of the state of the patient was 17 points at the moment of conducting the surgery. And talking about organ donorship in the Republic of Uzbekistan, you can see that at the both stages of the surgery, in most of cases, it was, of course, brothers, sisters, I mean the close relatives, and of course, according to our legislation, the cousins can also be donors, and the median age of the donors was 31 to 33 years, starting with 18 years. And the indicator of the weight of the liver, you can see for donor we are leaving at least 30%, and the weight of graft was 700 grams, and the distribution was from 0.6 to 2, and this is the reconstruction of liver and vena cava outflow. Nothing, I would say, principally changed. We are having the anastomosis of the liver vein from the right side, and we are also using these vascular prosthetics, and from fifth to eighth segment we are trying to help with additional outflow. Sorry, we are experiencing some problem with presentation. Not see our presentation on the screen. That is the issue why we cannot proceed. I'm sorry for technical issues. So here you can see this arterial anastomosis at these two stages. So we had significant changes, and actually this is one of the most, I would say, complicated stages of transplantology, especially from the relative donors, because you can see sometimes you have these veins as well as vascular, which have, I would say, different diameter, which are not matching up, which are not compatible, and as a result, you can see that we have developed a special technique to resolve this issue, and we are now trying to, of course, improve these issues. We are creating special, I would say, area with arteries of gastroduodenal duct, and also you can see this. There is a standard anatomy of liver veins, and also talking about this biliary reconstruction, especially talking about transplantation from a live donor. And I can tell you that talking about this biliary reconstruction, the number increased from 50 to 70%, and we have the same amount of biliary reconstruction. In most of cases, we had patients with 2 or 3 even points to be reconstructed. And once again, I would like to mention that the transplantation of liver is very important, and it is very, I would say, complicated surgeries in surgeon's practice. And at the moment, I would like to especially mention that the patients with no complication, their number grow from 34 to 50%, and the number of complication is also gradually reducing. So the number of such a surgery, I would say, surgery complication reduced from 57 to 19%, and we have less septic complications also, with the number reduced from 18.5 to 3%. What became the reason for improving results of specific post-transplantation outcomes. We had various scientific research, including thrombosis and hemorrhage complications, and we had joint research which gave us opportunity to identify the factors of risks of development of thrombosis and hemorrhage syndrome. So it was antithrombin 3, as well as other indicated like plasminogen, and all which could lead to thrombosis in 21% of cases. And talking about hemorrhage syndrome is an amount of blood loss which is around 1 liter within the surgery time, as well as fibrinogen level. And these conceptual fundamentals of hemostasis system correction and modification helped us to reduce the amount of thrombosis and hemorrhage complication. And you can see that, of course, it was not a significant improvement from 24 to 17%, but from lethality rate, it was 8.5 at introduction stage, and now it is less than 2% at the development stage. It's the major factors which produce its impact on progressive development of transplantology in the center of Vahidov. Of course, we should mention so-called multidisciplinary approach, since the transplantation of liver is the most, I would say, complicated approach. And at the moment, we can tell you that we can closely work with our teammates from other domains of medicines. Of course, we are having a high diagnostic potential, including biochemistry lab, ultrasound, MRI, CK. Of course, it's a high level of reanimation and resuscitation services, as well as, of course, the high level of X-ray and endovascular interactions. So we can, of course, find a better solution in terms of less invasive technologies. And talking about treatment of early stages complication and frequency of mortality, you can see that, of course, we at least can have so-called X-ray endovascular or percutaneous interaction. And of course, at the introduction stage, we had a high mortality rate around 24%, but at the moment among 52% of patients, the mortality rate is less than 10%. And at the moment, at the introduction stage, you can see the key causes of mortalities was, of course, cardiovascular complications. And at the moment, we had no issues. I mean, the cardiovascular issues which are leading to lethal outcomes, and they can be, of course, modified with less invasive surgery technologies. And of course, sometimes even we can prevent mortality even in case of acute hemorrhage, a stroke. And talking about long-term complication, the key issue is the biliary complication. In most of cases, we had only 50% of patients with no complication at all. And the center, at least at the stage of development, will have 75%, I mean, in long term with no complications. And you can see that both at the stages of development and introduction, we are having the biliary complication as the major complication. And of course, we have a high indication, a higher, I would say, rate of anastomosis related complication. And at the moment we can use less invasive technologies. Therefore, we have drifted away from open access surgeries, and these reconstructive surgeries number reduced from 60 to 20% thanks to the development of endoscopic service at the center. And considering our high potential and high level of survival, of course, the compliance with patient is also very important. And you can see that even at the introduction stage, the mortality rate was like 3 times higher. Now at the moment it dropped to 6.4%. And of course these complications were now set aside, but still we are coming across these biliary complications. And especially we need to mention that in most of cases we had this lethal outcome, and most of them were related to the compliance, which means the patients were not taking the immune suppressing drugs. They were not meeting the recommendation and instructions, and you can see the results of liver transplantation. You can see that at introductory stage the survivor was 62, and the hospital mortality rate was 24%, and the long-term mortality was 13%. And at the moment the survival rate is 83%, and 7% is a long-term mortality rate. And taking into account I would say so-called personalized access, personalized, I would say, approach, it is very important that in our country the mortality for us to be able to prevent mortality in our country from liver disease, we need to perform at least 200 surgeries a year. But in long term, it should be at least 3,000 surgeries a year, which means that we need to develop our transplantology departments all across the countries to be able to prepare patients for the surgeries and post-surgery treatment and follow-up. Of course, in a couple of years, we will have much more patients who have already undergone the surgery. And of course, only one center, which is our center, will not be sufficient enough to embrace all of these patients. Therefore, of course, we need to develop the respective centers all across the country, in the provinces. We need to develop so-called laparoscopic technologies, especially when we are collecting right and left lobe of liver from the donor. We need to support them in terms of pharmaceuticals and drug supply. And of course, we need to introduce the experience of the leading medical centers to the center of Vahidov, and to nurture and train our own specialists. You know that the liver transition requires multidisciplinary approach, and we need to be and work as a one team. And once again, thank you so much for your kind invitation, and the government of our country for paying attention to this center. Thank you so much. Yes, thank you so much for your interesting speech. Actually, I like people who are not hiding the complication, I mean post-surgery complications which are there. And just one question which I would like to ask. You have mentioned about this GRWR, yes, from 2.6 to 2. How often do you use the patient with the small weight of graft? I mean, with the graft less than 0.8 kg. From 0.6 to 2 is, I would say, this is the range, but annual, I would say, average is 1 kg. And after, I would say, intraoperationally, we measuring up, it was around 0.6. But I can tell you that from 8 to 10 such a transplantology surgeries are conducted meeting these criteria. It should be at least to 0.6. No, we do not do so-called modulation. We are not doing the preliminary modulation in advance. We need to do the transplantation, as they say. And actually, your government is also keen on pushing up with transplantation, but we need to, while the surgeries, we need to prevent, I would say, the death of the brain. Because people are thinking that we have a lot of organs somewhere in storage, but it's not true. Of course, we do not have the storage. We do not have a pool of organs, I would say. We have just started, and we need to develop what we need. I'm pretty sure that as time goes by, you will be able to resolve the issue. Of course, we are dealing with transplantology, and talking about transplantology of lungs, for example, we need to analyze when we are having these cardiovascular surgeons with us or cardiac surgeon with us. We need to keep in mind that we, of course, are engaging them, and they are doing it much better than us. That's why we're also having the children cardiosurgeon and surgeon who are helping us to do this complicated anastomosis of these small diameter arteries. And this is the way we are doing. You should not try to do it all by yourself. You need to engage the team. Thank you so much. just one thing which I would like to add from my side, that according to the law of the Republic of Uzbekistan, we also have this donorship from deceased donor, and of course this is, I would say, the best I would say attitude from the point of view of the donor's health state. Let me be very fair, it is very complicated issue in Russia. Only 9% out of 100 are ready to donate their organs, even to their relative. And of course, we need to teach people that, of course, you are giving your soul to the God upon death, but you have to give your body and your organs to people who are still alive. And of course, I'm very thankful to the President of Republic of Uzbekistan, and I'm very thankful to steering committee, because we are also working with religious scholars, because you know that mentality of our people, you know, even if you are having this mortality, and when you need to, I would say, do like go to cadaver, it is not easy, because the people are always opposing this, and together with the legislative chamber, together with Senate, together with Parliament, we will, of course, will develop the transplantation from deceased donor. And when we have been starting this, and we, I mean, the stepped in this domain, we had the academician Gautier, we had Mr. Ubudnya also with us, and other. I mean, it was a big meeting of the leading of the prominent specialists in this domain, and they have told us, just go ahead and do it, do not stop. Of course, yes, in Russia and in Belarus, the law is undertook based on so-called the presumption of concord. But in our country, but in Central Asian countries, we have presumption of non-concord, non-consent. I mean, in US and other countries, I mean, in 10 countries where donorship is developed, is the countries where they have the presumption of concord. Unfortunately, our next participant, Mr. Gautier, couldn't join us, and actually, because tomorrow they're going to have the lectures, I would say the meeting of the transplantologists of Russia, and that's why he couldn't join us. And I would like to express my sincere gratitude to Kadyrova Malika. Please, madam. And we would like to give you the floor to deliver your speech. Good afternoon, dear colleagues, my dear teachers, dear Mr. Said Murat Ibrahimovic and others, staff members of the Center of Republic of Russia, and upon your kind permission, I would like to deliver the speech on the name, on the behalf of director of the center named after Vishnevsky. And of course, the leadership and the staff members of the Vishnevsky Center are cordially congratulate the staff members of academician Vahidov on the 50th anniversary of their activity, which became a beacon of development of thoracic surgery and top-class professionalism all across the country. the center is the leading medical entity all across the Central Asia, and we are very proud that the President of Republic of Uzbekistan, Shavkat Mirziyoyev, and the President of Russian Federation, Vladimir Putin, signed a joint agreement on fostering cooperation in science, research, and development. Russia and Uzbekistan are a strategic partnership which have long-standing and proven relation, and we have managed to elevate our cooperation to the highest level. Our dialogue is based on mutual trust and strives for long-term perspective, and we have entered into scientific and practical cooperation agreement. The center named after Vahidov will be the place to have the ideas implemented into practice. And now, while it's anniversary, we have things to be proud of, and we would like to congratulate all of you with a 50th anniversary, and of course we would like to wish you to conduct the Vahidov readings 2024 in the most efficient manner. The director of the Center of Vishnevsky academician Amiran Revishvili, and as you know, since it's anniversary, we need to come up with presents, and 150 years anniversary of academician Vishnevsky was celebrated this week. We would like to give you as a gift the portraits of academician Vishnevsky. Please, on our behalf and on the behalf of the center, please, sir. Dear colleagues, I guess this is the time for us to proceed, and now we would like to give the floor to Mr. Ashrafi Ahmad Shah, University of British Columbia, Vancouver, Canada, laparoscopic repair of giant paraesophageal hernias. Добрый день всем, друзья. В первую очередь я хочу поблагодарить вас за приглашение выступить. Я хочу просто немножечко кратко поделиться результатами нашей работы в области лапароскопических операций. Мы вчера даже провели операцию. Это была вторая, собственно говоря, в Узбекистане операция, минимально инвазивная. В прошлом году мы ее провели, потом мы посмотрели состояние пациента, все нормально. То есть это была именно ситуация с раком пищевода. И теперь мы будем все-таки говорить опять-таки о лечении болезней пищевода. Я считаю, что это одна из наиболее сложных операций. Почему? Потому что, конечно, очень тяжело производить именно решение проблем, связанных с грыжами. Давайте мы поговорим все-таки об этих грыжах, и я покажу вам, конечно же, как это происходит. То есть иногда ситуация может быть противоречивой. То есть в первую очередь, конечно, показатели. Когда надо начинать? Надо ли начинать? у кого это можно делать, у кого это можно не делать, кого можно медикаментозно, то есть консервативную терапию принимать, а кому все-таки нам необходимо давать вот эту именно операцию. То есть, опять-таки, это исходит из нашего опыта, да, то есть, опять-таки, иногда бывает короткий пищевод, понимаете, то есть нам надо понимать, какая должна быть ситуация, и, соответственно, как мы будем решать ситуацию с пациентами, у которых идет повторная ситуация, или же, допустим, стоит это делать именно открытым доступом, или все-таки нам надо это делать через минимально инвазивный доступ. Что вообще это такое? То есть грыжа пищеводного отверстия. Иногда бывают врожденные такие, то есть люди уже с этим родились, и еще есть такие грыжи, которые возникают именно по мере хода времени, по мере того, как мы стареем, конечно, начинают развиваться различного рода болезни в организме, в том числе и грыжи пищеводного отверстия. То есть, конечно, мы понимаем, что все они развиваются по мере хода времени, по мере хода, к сожалению, износа организма, да? Причина в чем? Причина в том, что в большинстве случаев очень важно, конечно, это ситуация ослабления связок, понимаете, то есть у нас начинает развиваться вот именно вот эта вот хиатальная грыжа, да, пищеводного отверстия, то есть это у нас может приводить к тому, что у нас прямо вот это пищевод проникает уже в брюшную полость. То есть, вот смотрите, первый этап, первый тип, да, операции это как? То есть мы, допустим, у нас здесь идет соскальзывание пищевода, то есть по диафрагме. Второй тип этой ситуации это уже пищеводная, параэзофагальная идет, то есть у нас грыжа, она вот так вот выглядит, вот так вот. И третий это смешанный тип грыжи, когда у нас есть и здесь вот именно на диафрагме вот эта вот сама грыжа бывает расположена. То есть и самый сложный тип, это вот самый затрудненный для доступа, то есть вы видите, да, у вас или маленький кишечник, у вас короткие могут быть, там, допустим, толстый кишечник, или у вас в итоге вы даже просматриваете, даже у вас, допустим, желчный пузырь, у вас даже вы видите селезенку, вы видите здесь уже и даже желудок, то есть обычно у людей проблема начинается сразу же с рефлюксом, у нас идет очень большая проблема, допустим, с анемией, у нас начинается рвота, иногда нужна бывает и колоноскопия, то есть нужна, то есть у нас начинается так называемая эрозия, да, у нас, то есть постоянно вот эти вот тоже принципы, да, еще какой вариант есть диагностики, я думаю, все мы очень хорошо знаем эту ситуацию в медицине, то есть, допустим, мы, конечно, даем барий, да, в первую очередь, чтобы можно было просмотреть вот через раствор, затем, конечно, чтобы мы могли понять размеры этой грыжи, да, и, конечно же, есть ли какие-то проблемы, например, это обструкция, да, и, конечно же, когда я считаю, что все-таки эндоскопия необходима, то есть это в первую очередь, чтобы мы убедились, что нету раковых опухолей, чтобы убедились, что нет проблем и других существенных с пищеводом, и, конечно же, потом мы уже гистологический анализ тоже проводим, чтобы можно было посмотреть именно степень повреждения пищевода. Не всегда манометрия возможна, я это говорю, потому что это все-таки у нас может быть же обструкция у нас, но все равно в целом это проводится. Я хочу сказать, что иногда можно, не всегда, но можно провести компьютерную томографию. Конечно же, можно еще 24 часа вот действительно проверить именно опорожнение желудка, но это тоже не всегда, знаете, это такой достоверный метод, я бы сказал. И теперь, естественно, принципы операции, да, любая операция имеет свои принципы реализации, в том числе и именно когда мы говорим о грыже пищевого отверстия. То есть полностью мы должны желудок именно, скажем так, убрать именно вот этот вот грыжевой мешок, чтобы у вас желудок находился именно в брюшной полости. И, конечно же, надо подготовить вот полностью, нам надо посмотреть, не сократился ли у нас пищевод, потому что нам же нужна горостопластика тогда, иначе нам нужно как-то уже тогда делать, и уже после этого и должна быть операция, которая, скажем так, предотвращает рефлюксы постоянные. Как мы наблюдаем, то есть на протяжении короткого периода, до конца жизни, или только в период именно клинического лечения. Я вообще наблюдаю их на протяжении всей жизни, то есть каждые 5 лет эндоскопию я провожу. Я всегда, когда какую-то проблему у них наблюдаю, говорю, сразу же обращайтесь к нам, сразу по факту. И теперь вот результаты операции, вот мы видим, да, красное – это уровень рецидивов, и вот мы видим в основном, как операции проводятся, и вы видите здесь уровень 2,5%, обычно, это в целом это 15%, но метод операции обычно у нас проходит бессимптомно, и то есть, конечно же, сложности вот этих минимально инвазивных процедур вы сами видите, даже вот здесь вот вы смотрите, что сложнее, да, это справа, если, допустим, слева у вас идет доступ, операция, казалось бы, простой, да, то есть вы делаете операцию на жечном пузыре, а потом уже чем правее вы двигаетесь, тем сложнее становится. И уже именно ультраправая часть, это уже у вас, по сути, становится уже даже эктомия пищевода. Это не так-то просто, правильно? Эти операции очень сложны в выполнении. Я просто покажу вам сейчас один ролик одной из наших операций, которую мы провели. Посмотрите, это вот женщина, у которой была огромная действительно грыжа пищеводного отверстия. Вот вы видите, задача стояла в том, чтобы желудок все-таки спустить вниз, да, то есть именно в брюшную полость. И теперь вы видите, что у нас идет иссечение. Иссечение мы начинаем всегда сверху, да, вот из позиции 12 часов, 12:00. Что важно, мы должны начать именно иссечение мешка с позиции 12:00. И теперь вы наблюдаете, да, вот здесь вот у вас идет существенное уменьшение вот этого напряжения в желудке, потому что желудок остается именно в брюшной полости. И мы действительно очень часто она жаловалась на вот это вот сердечно-сосудистую боль. Я, конечно, старался полностью удалить максимально именно вот этот вот грыжевой мешок. Когда же вы его удалите, теперь самое главное, вы не должны повредить переднюю брюшину, переднюю стенку брюшины, да, и также мы делаем вот замену сосудов. Как? То есть мы зажим ставим, да, зажим поставить это не проблема. Я еще ни разу не видела в результате этого какой-то ишемии. Я могу сказать, просто давайте вот мы это разделим, да, и осторожно мы должны защитить переднюю стенку брюшины, и плевру мы выталкиваем, то есть чтобы у нас не было пневмоторакса. После этого мы иссекаем полностью грыжевой мешок, и мы вот до самого конца, то есть вот до кромки мешка доходим, то есть мешок уже полностью у нас освободили мы от перикарда и от плевры и справа, и слева. И, конечно же, вот если вы действительно правильно движетесь, то есть по правильной траектории, обычно кровотечений не бывает. То есть вы сами видите, да, крови у нас нету. Обычно, ну, может быть, 5, ну, в лучшем случае 10 кубиков крови будет потери, то есть это не так существенно. И вот смотрите, теперь я уже вот иду к срединной линии, да, вот к средней, к грудине, и вот мы видим, мы идем дальше уже, и уже вверх идем по грудной клетке. Итак, мы после того, как и находим уже сам пищевод после иссечения мешка, и давайте мы смотрим на аорту, мы смотрим на все-таки позвоночник, и мы стараемся максимально защитить аорту, то есть мы используем наши приборы, вот этот мешок, мы его отсоединили, грыжевой, давайте теперь вот мы именно освобождаем именно вот эти вот, скажем так, кромки мешка от плевры. И смотрите, слева у нас уже, видите, да, позвоночник, а вот если вы дальше пойдете, уже вот у нас идет пищевод, да. То есть нам очень важно мобилизовать пищевод, то есть, опять-таки, чтобы он именно максимально удлинился. Вот мы видим аорту, да, и сзади уже нашего прибора мы сейчас, собственно говоря, освобождаем пищевод от аорты, и вот, смотрите, мы движемся дальше, то есть мы идем именно к нужному уровню. Теперь у нас, видите, вы сами можете зажимы и поставить, или можете просто это распилить. Да, иногда может быть у вас здесь кровотечение. Я вам должен показать, если у вас кровотечение есть, это не так-то сложно его контролировать. Просто вы будьте готовы к этому, имейте при себе зажим, чтобы в нужный момент просто перехватить этот конец, и тогда, в принципе, это кровотечение легко контролировать, то есть это маленькие сосуды пищевода, желудка, это не настолько сложно, просто вот это расстояние вот мы перехватываем, и здесь мы ставим зажим. То есть, смотрите, я не говорю, что всегда у вас будет кровотечение, но если оно возникнет, вы можете вот к этой технике прибегнуть. Очень важно разделить вот эту вот артерию. Вы должны убедиться в том, что когда у вас именно вот идет соединение концов, да, чтобы у вас не было высокого натяжения. То есть вы должны понимать, как вот эти вот короткие сосуды не натягивать. У вас все-таки это должно оставаться вот так вот, это где-то, наверное, 1/3 должна быть достаточно свободной, мобильной, я бы сказал. И вот так вы сможете понимать вот именно эктомию пищевода, и вы можете узнавать именно, как провести вот эти вот минимально инвазивные операции на пищеводе. Конечно, эта операция предполагает мобилизацию желудка, мобилизацию коротких сосудов пищевода, и вы должны идти наверх, понимаете, да, то есть левая часть диафрагмы, вы должны убедиться, что все вы уже освободили, именно вот я имею в виду основание, да, вы должны именно с левой части диафрагмы это освободить. Вы видите, здесь действительно грыжа все-таки огромная, дефект существенный. И, конечно, все это можно восстановить, я имею в виду реконструировать. Главное все это освободить, чтобы избежать натяжения, да. И, конечно же, вы должны все и справа, и с левой части вы должны это освободить. Вы видите, здесь очень красиво все это сделано. Я имею в виду вот с ножкой, да, вот мы должны этот вопрос решить. И посмотрите, у нас идет мобилизация, нам нужно все-таки достичь хорошей длины. И вы видите, да, вы не должны повреждать ни в коем случае. Сейчас вот мы с грыжей разобрались, с отверстием разобрались, и вот сейчас даже, знаете, когда у вас очень крупные грыжи, все-таки очень хорошо идет вот наложение швов. Главное, чтобы оба вот этих вот конца сошлись без какого-либо натяжения. Знаете, да, натяжение это обычно означает неудачный исход операции. Поэтому вот сейчас вот мы завершаем реконструкцию именно отверстие. Следующим этапом после этого, последним, по сути, этапом будет, это, конечно же, я сделаю где-то 360 градусов вот приложения. Я не всегда это делаю, потому что нам надо контролировать рефлюкс. Это, наверное, все-таки лучше, когда его нет, то есть по методу Нисона. То есть, видите, да, здесь идет свободный маневр, это считается, что как бы просвет в обуви. То есть, смотрите, у нас идет от желудка, от пищевода, да, то есть вот я использую вот эти вот нити, и я еще раз говорю, при бужировании ни в коем случае, вот мы используем хорошее бужирование, то есть это иногда аж до 60 доходит, минимум 54, зависит от пациента, от его, скажем так, параметров тела, да. И вот опять-таки, видите, дно, да, вот я возвращаюсь опять к пищеводу, вот, и теперь мы уже делаем наш, опять-таки, маневр Нисона, мы это делаем, опять-таки, без натяжений. И теперь, в основном, знаете, когда мы говорим, вот наши пациенты, да, допустим, утром, если вы делаете операцию, вы уже можете их к ночи отпускать домой. Или же иногда вы их можете, допустим, оставить на ночь в больнице. То есть ничего страшного нет. Для болевого синдрома, для его погашения можно использовать парацетамол, но дополнительно чего-то сложного для них не требуется. Сама операция, опять-таки, еще говорю, надо избегать натяжений. И, конечно же, это нам помогает правильно наложить до диафрагмы. Конечно, у меня есть еще один видеоролик, может, я его вам просто на ускоренной перемотке поставлю. Мы можем поставить видеоролик на ускоренной перемотке? Да, давайте, вот сейчас я буду очень быстро его проигрывать. Давайте мы еще ускоримся. Смотрите, вот сейчас у пациента короткий пищевод мы видим, да, сами? Что мы должны сделать? Мы делаем гастропластику, вы сами это видите, то есть нам надо все-таки удлинить пищевод, то есть, смотрите, мы все-таки от желудка чуточку сокращаем желудок, да, резекцию делаем, чтобы вот это сделать, то есть мы используем своего рода зажимы, и смотрите, что происходит, мы проталкиваем сипер дальше, и это нам дает в определенное пространство для наших линейных степлеров линейных, и мы вот небольшое пространство создаем, которое напрямую, то есть делает наш пищевод где-то на 5 сантиметров длиннее. И вот смотрите, нам обычно, если вот эти вот соединения есть, да, нам надо открыть желудок по сути. Мы используем наш так называемый линейный степлер, потом мы бужируем. И вы видите, да, мы это разделяем. И уже дальше операция, в принципе, идет по той же процедуре, как я и говорила вам. Разделили, у вас уже длина появляется дополнительные 5 сантиметров у пищевода. Теперь мы уже начинаем делать именно по методу Нисона дальнейшие наши шаги. То есть, видите, да, опять-таки, это идет по Нисону. Большое спасибо за внимание. Да, большое спасибо, уважаемый профессор, за вашу презентацию. Она действительно отличная. И, коллеги, у нас есть вопросы? Да, вы знаете, лично у меня есть свой вопрос. Смотрите, вот если у нас рецидивы, да, то есть вот действительно по повторной ситуации, вот из вашего опыта, давайте посмотрим на международную статистику. В большинстве центров, где действительно эти операции поставлены на поток, уровень там 14-15% рецидивов, но эти рецидивы идут без симптомов. Смотрите, мы провели 1000 таких операций, и у нас тоже 15% был уровень рецидивов, но повторные операции мы не делаем, обычно мы просто уже их наблюдаем. Рецидив – это первый тип, и если у вас нет симптомов, значит, это очень маленькая грыжа, и значит, если у вас очень высокий тип, уже, то есть высокая степень, да, грыжи, это, значит, говорит о том, что нет. Но, знаете, я мешки не использую. Мешки, то есть я вынужден уже использовать это, я прошу прощения, сеточки, только в случае, если уже очень большое отверстие. Thank you so much. It was a very brilliant report. I would like to thank our interpreter because it was very brilliant presentation. I would like to see our translator. I would like to see our interpreter. I would like to thank interpreter. Of course, we have been talking to our professor, and I have invited our professor to Krasnodar city, and he's a brilliant specialist, and of course, we have been working very proactively. We need to learn from each other. And thank you so much, and indeed thank you so much for your valuable remarks and comments, and of course at such a reputed conference we are having the best interpreters, and of course now we would like to give the floor to the thoracic surgery department, robot assisted surgeries in thoracic abdominal surgery in Krasnodar. Please, Mr. Parhanov, you are the hero of Russia Federation, so this is the time for you to take. My dear colleagues, it is our time to share our experience. We have two Da Vinci robots, and thanks to the governor's mayor's office, and we have our medical surgeries put into operation. I mean the robot-assisted surgeries. We have these Da Vinci robots. We do not have so much of them. Of course, it's not that much comparing to Western countries. We have various modifications of Da Vinci, which we are buying from China or in Russia. And in Russia, we have performed around 30,000 of surgeries, and our surgery department is conducting surgeries with robot assistant manners, and we have 564 surgeries in thoracic, over 1,800 in urology, and also coloproctologists, over 230 surgeries, and you know, we are giving the book. And we will send this book to you. It is called the Atlas of Surgeries on Vascular Surgery. On vascular surgery robots, and you can see that we had urology surgeries, as I have mentioned, over 1,800, and the prostatectomy were performed over 1,300 surgeries, and the center of Vahidov will buy this robot, and if you will have this urology department, you will earn a lot of money, because as I have already mentioned, males will understand me that after the surgery, after prostatectomy, you will have the impotence, and of course men are coming for robotic surgery not to face the problems with their sexual life. And also for thoracic surgery, lobectomy, we had over 362, segmentectomy 86, and bronchoplasty 19, and etc. So this is the typical resection. We have so many surgeries, and pneumonectomy, you can see that we have arteries, and everything is done in proper manner, and we are passing it by. And of course, we need to work and I would say, to reduce the number of complications. And at the moment, our surgeons, of course, cannot go to foreign countries due to sanctions to learn and to get from somebody else's experience. So look at the bronchoplasty. We had 16 bronchoplasty surgeries performed in a robotic assistant manner. We are ready for resection and bifurcation of trachea, and I'm not sure whether the video will be played, but anyway, you can see that. Give me kindly clicker. Kindly give me clicker. So this is the clicker. Well, thanks. Let me do it my way. How it is going to work? Well, okay. Here we are having this anastomosis, and here we are having the bronchs. We are simply doing uninterrupted regular stitches. And we have the Professor Palavinkin, who is dealing with coloproctology. He has conducted over 237 surgeries, including the anterior resection of rectum 87 and the resection, one resection, and you can see that we had ectopexy 5 surgeries. So here we have general surgeries. One of them is my deputy, Mr. Baryshev, and Mr. Arsen Popov, and I will ask our Canadian colleague to share the video and share the report so that we will show this method for us to introduce these methods in our practice, and it will help us to boost our experience. We had resection of liver 11, distal resection of pancreas, 10 surgeries, and you can see indeed we are progressing. And the general surgery, you can see this robot assistant fundoplication is 50%, and distal resection of pancreas 1, and resection of liver also 1. And for gynecology, 178 surgeries. We had hysterectomy. We had over 200 surgeries, and surgeries which are performed by our gynecologist. And we had, since December 2021, over 178 robot-assisted surgeries in gynecology department. We have managed to reduce interoperational hemorrhage, and especially the opportunities are now available to conduct surgeries in case of comorbidities and in case of obesity, as well as also we are conducting the surgeries in women in fertile age, and also talking about cardiovascular surgeries, vascular surgeries, 85 surgeries. We had linear prosthetics of aorta. We had stanting surgeries. We had the prosthetics on aorta and femur. We had aneurysma surgeries and decompression. And I just remember my friend who is now 70-year-old, academician Belov. Who knows him? Academician Belov is the head of department of aorta surgery in the Russian Medical Center, and he had the surgery conducted related to the stenosis, and this surgery, was conducted in most of cases in so-called open access. But now, can you imagine the open access surgery conducted, the celiac artery surgery conducted in laparoscopy? And look, we have been using the robot Da Vinci, and you can see how many points of access. You can compare the laparoscopic access and open access and see the result. This is the resection of aneurysma of spleen artery. Resection of aneurysma of liver arteries, and you can see here it is autovenous arteries, and you can see how the bandage are done on left kidney artery. And very good quote that you need to try to fly once, and always you will be looking at the sky. So the advantages of robot-assisted surgeries means that robot has the 7 degrees of freedom of movements, 90%, 90 degrees of movement, articulation, and for example, you know, the surgeons will face no problems because there will be no tremor, no hands shaking, because the doctor's movement will be, I would say, stabilized, and you can easily use both endoscope and the tools and the surgery tools, and you will face no problem. You will get this ambidextry, you will get the 3D, and you can have the optimized video control. And of course, it will give you the better opportunity to conduct the surgery because the surgeon might be sitting, and it will reduce the amount of number of conversion, and it will give the better, I would say, long-term forecast. And of course, the robot should also proportionally give the better opportunities. And of course, only there will be a limited number of patients subject to this surgery. There are centers where they're not using simply the robot. Robot is bought, it is there, but you are not operating. I will show you the slides which are not ours, but the slide from the company which is selling this robot. And look at this. You can see now the wound in artery. And look. And this is not the trauma which was showed by our Canadian colleague, but you need to be keep calm. You need to do the way it has been told by the leading surgeons, that you should not create additional damage because of your, I would say, concerns, and because of your handshaking. And of course, you need to avoid the conversion to open access surgery. And so, no bleeding. You should put your clip, and that's it. And now the surgery goes on. So now we are finalizing it with arteria. And we do not have, unfortunately, the tool which you have. We have seen your tool and we admire it. Look at the equipment which you have been using. I mean, Mr. Ashrafi Ahmad Shah, and we need to be ready for conversion. You know, sometimes you become too self-confident when you are conducting these laparoscopic surgeries, and sometimes you do not know how to open, and I mean how to get this open access. You know, the conversion, it is better when you are doing it in the same room, when you are not moving the patient from room to room, you know. And of course, you are having a lot of tools with you, but you need to be very accurate in what you are doing. And look at this book by Rauf and Pekin from Institute named after Herzen. And this book is very good manual for all of us. And of course, this is the algorithm of action to prevent intraoperational hemorrhage, and talking about experience, talking about the frequency. Of course, you can see that intraoperational hemorrhage, which was related to the type of surgery, you can see, and this is the statistics for Russia in 2023. Look, number one is Krasnodar, our region, where we have conducted the majorities of robot-assisted surgeries. Here the statistics for Russia for 2023. You can see the number of surgeries, 797. This is the hospital where I am working, clinical hospital number one in Krasnodar city. And we have other centers, one after the other, but anyway, I can tell you that all of these surgeries are conducted in Russia, and I am going to send it to Tashkent. I mean, the number of the books, I would say, the guidelines which you need to read. You have the team of authors who have developed these books. But anyway, please, Otabek, kindly share these books with everyone. And thank you so much for your kind attention. Dear colleagues, in case of any questions, well, Sellers, thank you so much. Indeed, it was a brilliant report. I have heard so much about your clinical hospital, and of course, I'm dreaming to go there and to learn more from you. Thank you so much, sir. Colleagues, in case of any questions, please feel free. Well, question from my side is about the compensation of expenses, whether the government is compensating it or not. Well, actually, we had Simashka, the first minister of health in Russia, and they have asked for the free, I would say, treatment. And indeed, in our hospital, which is state-owned hospital, our hospital, so we are rendering services for free. But our doctors are going to work in private clinics because they want to earn more. Of course, as a state-owned entity, we cannot pay them the way they want, but we are letting them, giving them an opportunity to come, I would say, to work in both places as a part-time job. And I can tell you that I had one friend of mine who was working in a state-owned clinic, and he was conducting 95% of his surgeries, earning only 5% of his income. And 5% of surgeries he was conducting in private clinic, earning 95% of his income. So I'm also permitting my subordinates to do this way. Otherwise, how are they going to cope with this situation? How are they going to earn? So talking about the experience of transplantation of surgery named after Sisganov, please, Professor Baimahana, floor is yours. Well, upon your kind permission, I would like to share my experience on liver transplantation in our center. Well, talking about the history of the transplantation of liver from deceased donor, we have conducted it for the first time in 1979, and the first liver transplantation from deceased donor in 2011, the first transplantation from a live donor, and 2012, the first cardiac transplantation. Then we have a heart-lung complete transplantation from live donor, and since 2013 we are conducting also pediatric transplantations, and since 2016 we are also doing a separate transplantation of lungs, and in 2019 we had 2 grafts from 2 donors transplanted, and since 2019 we have conducted over 2,000 of transplantation and over 500 transplantations for livers. And you can see a sharp decline by 2020 because over 8 medical centers jumped into transplantation, and some of centers were limited in conducting the surgery. Some of them were prohibited at all. And So talking about this transplantation from deceased donor, we are in the end of the ranking, but in terms of transplantation from a live donor, we are holding the leading places. And you can see that the transplantation is growing at least 8% a year, and I would say 25% of transplantations are conducted from live donor, but they're not meeting even the half of the demand for these surgeries. And as I have already mentioned, we had 8 centers, but it is not true. Because government, it was not, I would say, the right attitude, because government started to developing transplantation all at once simultaneously at 8 centers, and only 2 centers, it's our center and the center of Astana, only 2 of them are conducting these surgeries, because the government was not focused, I would say, on nurturing human resources. And we had over 300 transplantations of synergies. Majorities of them are from a live donor. The programs from deceased donor are not well developed. The program, I would say, is not working well, and I'm pretty sure that it will not move in coming years. And talking situation with Uzbekistan, we would like to see the situation in Uzbekistan. We had these vaccination surgeries, and thanks to this vaccination program, the number of patients with hepatitis B drastically reduced. In most of cases, the donors are siblings, children, and 63% of donors were young, up to 33 years. Well, talking about the selection, indeed, it is very important, because majority, the key issue is that it should be a 0 mortality rate. For this, you need to be a properly selecting patient. We have checked over 280 donors, and around 60% of them have been rejected, especially 30, I guess 60% of them were rejected in the second stage because of the small size of remaining of the liver. What should we keep in mind while transplantation of live donor? First of all, we are keeping in mind the veins of FIS and ACE segment, and of course dominant of liver veins. And there will be no issues and no complications. You need to keep in mind the diameter of arteries, and we face no problem with multiple arteries, because we have so-called retrograde blood flow. But anyway, the key issue, the challenging issue, is the dissection of arteries. And talking about biliary issues, it is not also, I guess, some sort of contraindication for the surgery. But anyway, you need to deal. You will anyway deal somehow with hemorrhage. And talking about the right lobe, the key issue is that in 50% of cases, talking about the transplantation, it should be FIS or A segment. I mean, the diameter exceeds sometimes 5, or even if it's less than 5, if you have a smaller graft to overcome the certain syndromes, we are trying to recover even such a small limbs. And of course, sometimes we can use even the segment of original liver, the host liver, for reconstruction. We have developed our own methods, and we are having so-called the crossectomy, and we are conducting this subcutaneous veins, which we are using for reconstruction of kidney artery. And now talking about the veins, sometimes these portal veins might be a contraindication, but we are trying to use the veins from the liver of recipient. It's very important, of course, keep in mind so-called the modulation. So you need to go for modulation, or keep in mind this process to prevent this hyperperfusion syndrome. When you have, I would say, the perfect donor, and you have the recipient with a proper health of state, it's one thing. But absolutely other thing when you have the perfect donor, but the recipient's state is not that good, and of course, it's not that, I would say, complicated, but still there are some health issues, I would say. So in such a situations, we need to, I would say, check the blood flow, and after assessing this blood flow, we are clipping these arteries, and I mean, you will decide how to deal with this situation, but in most of cases you can go with simply clipping to improve this portal blood pressure. But when you have the perfect donor, of course you need to, I would say, you need to anyway avoid this situation because they will not lead to any good outcome, I would say. And of course, you have so-called pre-operational prediction factor, which can predict you so-called hyperperfusion. And of course, you need to keep in mind, I mean, the specialists who are expert in this domain, they are well aware about the parameters to ensure the regular blood flow. And talking about blood flow, we need to keep in mind so-called results of orthometry. And of course, you can even visually, I would say, give the assessment based about this hyperperfusion. And some authors are providing do it before, some authors propose to do it after surgery. But you know, this hyperperfusion situation might lead to complications, and you will not be able even to deal with the situation in a moment. Well, we are, in case of hyperperfusion, we are going to clipping these stents, including even this liver vein, of course. In case of communication and flow to the liver vein, as I have already mentioned, the key issue here is these dissections. We are not, I would say, using this margin to margin anastomosis. We are doing end-to-end anastomosis, and we're doing it before surgery, and then we are deciding about the surgery. I mean, if we are doing it on the right side, it's one thing, and then we are going to the posterior segment, or if it's going on the left side, then the arteries are separated as a second, third segment. So we need to select it properly. I mean, the arteries of graft to be I would say divided. And talking about the liver artery, it is not, I would say, very important, because never in my practice the second of artery, in case of you have this retrograde blood flow, it will not create any issue, or it will not cause any necessity to deal with this second artery. Well, talking about this section, of course, it might be a problem in the patient who have undergone embolization, and especially before transplantation of the patients. And what are the complications? Actually, the major complication is in donors, because there might be a liver insufficiency, and of course, even if the patients are all right, they have no steatosis, it doesn't mean that they will not face any issues in the future. And for example, in case if in 5 days this bilirubin is increasing and prothrombin is decreasing, then you might face that there is the, I would say, the liver disease is coming along your way. But anyway, we are strictly monitoring this situation. I mean, hemostasis issues are also under control. And talking the issues which are faced by recipients are biliary complications, but with arteries, with thrombosis, by now we have never faced, and we are very happy happy with this. And talking about this section, well, here is our experience, which we have published in US. You can see that we have been using here subcutaneous veins, I mean ileum veins, and you can see that we have taken it, we have developed the graft, which we have been using for anastomosis. And talking about biliary complications, well, in most of cases, they are here, and 5 or 6% of biliary complications probably, I think that this is not the thing which you might hide, from the others. I mean, there are some doctors who are saying that they face practically no complications, or that they face a minor amount of complication, but it is not true. Still, it will be 10-15%, and I would like to keep in mind this classification of PAN-E. We, of course, have been using this classification, and we see this correlation between these anatomic, I would say, features and the angle of posterior lateral sector, because in most of cases it can easily be, I would say, divided with strictures, and you can see that even here, at least from our experience, what are the anastomosis which you are doing? It's biliary anastomosis. We are not using, for tactical reasons, this anastomosis with intestine. I guess that we can do it antegrade manner, we can do it in other manners, and they have no issues. And of course, do we have or no our drainage, I mean external drainage, and of course we are focused on developing the strict, I mean, we are focused on prevention of development of strictures, and of course it will help us to reduce the number of complications which we might come across. And talking about, I would say, modifications and correction, you can see that it can be done endoscopically. We can go for PTBD, we can go for rendezvous, and in 74% of cases they were quite efficient. And each 3 months you need to change, replace the stent. Sometimes you can do it biannually, but we had even several cases when these complications led to the development of unfortunately lethal outcomes, but it was just 2% of cases, luckily, and in 5% of cases we went for retransplantation from the relative donors, and in 2% of cases from deceased donor. And I would like to show you the complexity of conducting this surgery. We had 2 right portal veins, 2 right veins, and here we need to, of course, revive this segment, and we had 10 anastomosis here. This is the patient which underwent 3 chemical embolization, and as AFP was reduced, you can see that the transplantation, this is the 3rd option of portal vein, and in such a situation, it means that you will also have various, I would say, problems with the biliary ducts, and you can see that here we are using this section. We are using, I would say, very soft approach, and here is the portal vein. Right one and lower one are cross-cutting, and then I have told you this is the previously dissected the part of vein of the patient with varicose disease, and you can see how we are going for thrombosis. This is the only option which we're using. We face no problem because we do not use any prosthetic, because you know the problems related to infectious lesions of prosthetics are quite high. So we are trying to avoid this technique. And this is the host and the liver, and this is the graft. So you can see this is the right liver vein, and we are now conducting reconstruction. This is the right lower segment. We should reconstruct all the major veins, but there's no issue over here. And we are connecting the veins from fifth and eighth segment with the median and the left vein. And here we are having so-called orthoportal anastomosis with reconstruction of the vein. So you are seeing all the arteries, no issues. We're doing the end-to-end anastomosis. You can find the arteries with matching diameters, and the minor mismatch is not an issue. We are not engaging any, I would say, surgeons, cardiovascular surgeons. We are dealing with the issues ourselves. And talking about pediatric transplantation, the key issue is the pediatric diagnostics here, because in most of cases, children are coming in 5 or 6 months old, children with very, I would say, complicated situation, severe cirrhosis, when you cannot doing the, I would say, diagonally by axis. Therefore, the diagnostic issue is very important, and it's better to have the oblique access surgery, because according to Japanese experience, in 40% of cases there will be no need for the transplantation of kidney. This is our DLT, and you can see, of course, the children with a small weight, you need to go for reduction. We are going for reduction, and this is the result from our side. 77% is survival rate is 10 years, and considering this left lobe, yes, of liver, which might cause some adverse syndromes. Therefore, you know that the left lobes are, I would say, worse comparing to right lobes, but the 10-year survival rate exceeds 80%. We need to have this international cooperation. We need to share our experience. You need to learn from those who are more experienced, and this is the conclusion from my side, that we had 8 teams started simultaneously, and we have only 2 teams at the moment which are working. Therefore, you need to have one leader, and the others should follow the footsteps, and we can develop then, I would say, multidisciplinary team, and of course, it will produce nice results in the end. Colleagues, any questions? Do you have any questions, please? Well, colleagues, it is very interesting presentation. Can you please kindly? Well, please, colleagues. We will give you a microphone. And yes, kindly switch on your mic. Well, talking about children, I have already mentioned that the children with a small age, for example, the children with the weight of probably 8 kg and elder than 1 year, who is like weight is like 5-6 kg, who are coming to us in severe condition, who have practically full decompensation. The results are worse. It's around 50%. And talking about the transplantation from deceased donor, what about situation in Kazakhstan at the moment? We had very nice results initially, but then we also came across with some, I would say, some negative publications in social media. Previously, we had the presumption of concord. Now we have the presumption of non-concord. And we are now trying to go for the presumption of concord, but we have million times had a meeting with the representatives of all religious confessions, but it produces no result. No one wants to donate their organs after their death, and now we would like to go for other, I would say, incentive mechanism. In South Korea, they're giving 10,000 of USD just for, I would say, these funerals. Ceremonies, yes, in case if the family will agree to probably to I would say give the consent to use the organs from deceased donor. Colleagues, who is dealing with transplantation? Probably you have some questions. Colleagues, you have your microphone. Please kindly ask your questions. Well, how often do you have the syndrome of smaller lobe in recipients? Well, we are doing all the assessments before surgery, pre-operation, pre-ops, and we are checking the blood flow, we are checking the blood pressure, we are checking the blood flow in liver. So this is, you cannot predict it. You need to have certain parameters with which you should match. Otherwise, you cannot simply go on. We had the cases of so-called lesions, but still the patient, we have managed to deal with the situation because the donor was quite young. It was 18 years old, and the situation will happen. They are there, they will be there, but it is better not to have any consequences because it is not easy to fix the consequences. Just I would like to give some remarks, some concluding remarks. First of all, you should not forget, Otabek, let me just, I will give you the floor. You should not keep, the details of surgery, of course, the experts will discuss it. But, what does it mean to have the syndrome of hospital number 20 in Moscow so many years ago, while the kidney transplantation, the government organs, the government came while the surgery, and they have, produced adverse impact on the surgery. And they have been showing, on social media that if the person is dying, they're taking the organ from the deceased body. And of course, people were scared. I will tell you that in Minsk, the president of Belarus has ordered to take donors from the human body. We lack organs. The whole world is lacking organs. So the doctors who are working here, they do not want to take organs, and we are asking them, why aren't you taking the organs, for example, in Sochi city in Russia, or in Novorossiysk city in Russia, or in Armavir city in Russia? Because they're scared that people will simply be furious. We are having the, I would say, patient, yes, and actually the doctors are monitoring would it be strokes or wounds, and if we are treating the patients, probably we will be able to treat around 30-35% of patients, and it's not an issue for us, but the doctors are opposing. They do not understand how important it is not just the patient's audience, but also doctors do not understand it. You are the doctor, you're working, you understand. I'm always calling to the head of the hospital. No, we need to, we need to battle all these superstitions. We are in the end of the ranking of transplantation. You have seen this table. We know it. We know this ranking, what have been done in Moscow, what have been done by Bakeri academician, and in Russia also, and all of them. I mean, if the doctors are not putting the proper diagnosis of the death of human brain, you will not be able to deal, because yes, you're right. For example, in South Korea and in other countries also, each of the doctor is reliable to provide information and produce the report. And if the doctor has not helped to the patient and the patient has passed away, the doctor will be brought to criminal liability. In France, for example, each hospital will get 50,000 euro for each of the transplantation. But if you will be coming with incentives to help up to engage more people and more doctors in transplantation, it will help us, of course, to satisfy to a certain extent the demand for organs. And of course, we need to nurture specialists. The doctors should be properly trained. They should understand it. They should have, I would say, the broader scope and the vision. Otherwise, of course, within 5 years, you are going for example, for a bachelor's degree in medicine. You are passing all the exams, but you are, and in most of cases, you're understanding that you want to help somebody, but you cannot understand that the help is not about treatment. The help is also about, I would say, timely taking the donors. You know that the country, I mean, in Russia and other countries are now engaged in war, and they miss organs, they lack organs, and they came here and they have met Mr. Kryukov, who is the principal of military medical academy. But and Putin asked whether the civil hospital are ready to render their assistance with the organs, and he responded that yes, of course, the principal responded, but can we do it or not? We do not know. Because for this we need to prepare it. So we need to work on this extent, and now we would like to give the floor to Mr. Hadjevaev, Muratov, and etc. And we will be discussing about concomitant injuries. Please. No, I guess all of our military medical doctors, they are not here with us. That is the issue. Youngsters, you need to listen up. You should not leave. Well, good afternoon, dear colleagues, my dear colleagues. It is my pleasure to share our experience about surgical treatment of close injury, of concomitant injuries, according to the WHO 2021. This is the major reason of death in age by under 45 age, and you can see that the polytrauma and concomitant injury in most of cases is related to technological factors. And in Uzbekistan, in emergency medical assistance center, we had over 2,000 of patients, and you can see that the annual rate of hospitalization is 10,000 people, and you can see that in cases of concomitant injury of abdomen and thorax, it's quite high. So it means that annually we have over 445 patients, and according to the structure of trauma, you can see that with no trauma of thorax we have 45%, and only thoracic trauma with no abdomen is 30%, and in 22 and 3% of cases it's concomitant injury. And you can see that we have, for example, traffic accidents, as well as majority of patients also came here to the hospital after the traffic accident by the emergency, by the ambulance, and a majority of patients were delivered to the hospital in 3 hours after the injury, and 72% of them were males, and the hospital mortality was 6.5%. And you can see a clearly expressed correlation between age and mortality. Concomitant injury in most of cases is also coinciding with a cranial trauma and limb breakage, as well as breakage of bones of pelvic. And we have also studied the patient with concomitant injury of abdomen and thoracic, including laparoscopic and video thoracic scanning. You can see the CT scan of results of concomitant abdomen and thoracic trauma, and you can see the result of ultrasound diagnostics. And you can see that here we had the amount of liquid which we had in the peritoneum, and we had our own, I would say, ranking of for assessment the amount of liquid in abdomen and thoracic. And it's very peculiar to have rib breakages, and the patient in such a situation, they had breakages of at least 2 bones, and majority of patients came in shocking situation, and some of them in most of cases even couldn't deal and couldn't understand due to the shock what is happening to them. And we have already identified so-called subcutaneous emphysema and hemothorax, pneumothorax, and hemopneumothorax. In 45% of cases, we have developed new methods of fixation of poly and floating breakages, and we have used this method in 168 patients, and we have managed to based on the results of correlations which we have checked, we came up to check as a major diagnostic criteria to understand the amount of liquid in thorax and in abdomen. So we have developed the algorithm to develop the tactics of treatment. So the amount of liquid should be less than 50 milliliters. The surgery should start with diagnostic laparoscopy. In case of amount of liquid exceeds, we can do with laparoectomy, preliminary laparoectomy, and also in case of so-called video laparoscopy and laparoectomy, and in most of cases for pre-operational drainage, it ended with the open access surgery, and in case of concomitant injuries, they face the diaphragm ruptures, and in most of cases it was happened in left lobe of diaphragm, and in majority of cases we had a number of rib breakages, and also we had the problem of with esophagus, with colon, and majority of patient with up to 300 milliliters, they had no check, no cases and no requirements in laparoectomy, and in 2.3% of patients we had around 3 to 500 milliliter of blood in the abdomen, and we easily deal it with laparoectomy. And the causes of lethal outcome were related to of course shock and pneumonia and sepsis, and also in these particular cases, started from 25 years of research, we have seen the results of mortality rates which are reducing, and annual mortality rate is reduced significantly now. So we think that this is the major reason of the patients, of lethal outcome of the patients who came after traffic accident. And the key issue is the violation of rule of golden hour, when the patient should be urgently transported by ambulance to the hospital. The patients with concomitant injury should be hospitalized to the ambulance department according to the algorithm developed by us, and all the all the specialists to treat should be there in all of the respective domains to examine the patient pre-op, and also we need to improve the post-op result. The transportation of patients with concomitant injury should be done with the special teams and in the vehicle which is equipped with all the respective equipment. Thank you so much for your kind attention. Well, thank you so much. Questions? There should be questions, I guess, because it's very important. Please kindly give the mic. Just a moment. Do you have so-called simultaneous laparoscopic and endoscopic checks in case of concomitant injury? Well, according to the rules, as soon as the patients are coming to the specialized centers, we have first of all the shock stage, because in most of cases these are persons, these are patients with so-called shock and shockogenic situations. After checking him, yes, we are of course defining the tactics of treatment. Talking about simultaneous, yes, we can conduct several times. I mean, 2 or 3 surgeries can be conducted while the patient is under the anesthetic diagnosis. So, have you received your question? Yes, one thing which I would like to tell you here, when we had so-called video thoracic access measures, it's very important. They have introduced the so-called video thoracic scopies while military injuries. I was like, no, we do not have time for this. And in one foreign book, I have wrote that the patient is coming with polytrauma. They coming with Da Vinci robot, you know, because you will be putting the ports, the patient will simply die. In the situation, there are some situations when you are rushing. Of course, you know that the patient sometimes is not rushing. You can, of course, measure his body and find the place to put the port, to introduce the port, but you need to be aware what is the amount of blood for drainage, yes? If you have indications, you need to go for draining, and of course you need to be very careful because the rule is here. If you want to be peaceful, you need to be well prepared for the war. Therefore, you need always keep in mind that if something will happen, we need to go. You know, sometimes you do not need these methods. I mean, these state-of-the-art methods. Imagine that while the military combat, the patient will come and you will be doing this thoracoscopy or you are going to this endoscopy. It's not reasonable actually, and it's not, I would say, appropriate. So you need to finish it up, you know, really. And now we would like to give the floor for the National Center of Almazov. Please, state-of-the-art technologies of peri-op nutritive metabolic therapy. Please, Mr. Lederman, floor is yours. So good afternoon, my dear colleagues. It is my pleasure to be here with you. And of course, I would like to congratulate you on your 50th anniversary and wishing you 50 more years. In my short report, I would like to brief you about our experience in interacting with the patients who are to be prepared for surgeries, and of course to share the technologies which we are using to, I would say, ensure the situation with complications. And kindly check my presentation. This is not mine. This is not my presentation. colleagues, when we are talking about our patient, of course, there are a lot of issues and questions which are here. Sometimes you're thinking, there's not an issue, come on. But anyway, it is an issue, and we need to find, I would say, the remedy for this challenge. I have been working in surgery clinics and even at the chair of surgery, and I will tell you that the most complicated answers are coming to the most simple questions. So I would like to develop these so-called clinical recommendations, and under the Federation of Anesthesiologists, we came with developing so-called clinical recommendations. So in my 10 minutes report, I would like to discuss about this peri-operational nutritive support and about practical implementation of this in real life condition. We are thinking, should we or shouldn't we prepare the patient for operation? What about his nutritive status? It is not easy. You will not be able to assess everyone. And you need to find, I would say, some simple remedies to identify the patients who need the treatment. There are so many screening ranks, but all of them, all of them have the right for usage, but still, for doctor, this one is more, I would say, preferable, because only in 1 minute you can easily check the patient state and predict the risk of complications. And of course, the key issue, look at the albumin level in blood. The level of albumin is, it might be some sort of predicative factor to have ideas that after, post-op, there might be issues. So only if you know this first level, albumin, in other markers can also be assessed. You can waste money, I would be very frank, to check whether it should or shouldn't be, the patient should or shouldn't be taken to the surgery. Everything is quite simple, I will not comment, but the key issue is that in most of cases you are not conducting this complex assessment, and who is the patient to who will be prepared for the operation. I can tell you that in most of cases it's oncology clinics, because in oncology you need to be well prepared for surgeries. Otherwise, the surgery will not be successful, so it will be technically perfectly implemented. So you need to have two of these criteria. Any of these criteria to say that the patient cannot survive the surgery. And in 2017, we had this high development risk indicator. But you look at the patient, he is all right. But you have some minor indications that the things will go wrong. Minor, but still they are very important. For example, it's the loss of the body mass. At least 10-15%, and blood albumin. And look here, dear colleagues, when you are working with the aged patient with body mass index which is less than 20, but for elderly patient it is not proper weight. First of all, you need to go for sipping. What is sipping? In Russia, we do not have this word of sipping, but doctors are using. It means that the patient need to eat these special mixtures. They eating it together with meals, and this is one of the most important principles that you need to explain the patient, that it should not be tasty. but you need to eat it anyway because it will produce nice result on your treatment. If you are informing the patients in advance, the patients will be very well aware that it's very useful. But it's better to explain person that it's better than going for so-called parenteral nutrition. And there are several, I would say, principles which you need to keep in mind, that these nice, good-looking bottles, they of course have different flavors, and patients are treating them as I would say as a juice. And as a result, they are facing the problems with dyspepsia, nausea, and vomiting. Therefore, in 1 or 2 hours after meal would be better. There are so many mixtures that you can easily get confused. Therefore, you need to classify them. For example, we are also classifying the drugs, the antibiotics, the infusion environment. So it's very important whether it is sweet or not. It's very important for our oncology patient, because oncology patients, they do not want to have, I would say, sweet content, and we are giving them, and patients are consuming things which are not sweet, and this technology is quite difficult because the patient sometimes sees no sense in eating these flavors. Not all the patients are ready to drink and drink and drink these mixtures. Sometimes patient can drink it, can add it to what they eat, or patient can make a cocktail or dessert. And we had even a book in German language translated into Russian, how these, I would say, not tasty food with no taste can be made a bit tasty. And of course, patients are okay with this, and it's better than have majority of patients that we have. The doctors are well aware regarding what is fast-track surgery in patients, and in my practice in one of these logical surgical department, we understood that sipping these drinks are very important for a peri-operational preparation. And if you have, before surgery, in fast track, it should be just 2 hours of fasting, and after surgery, we need to feed the patient as soon as possible. And according to European guideline, we need to now probably match these guidelines with reality. So it means at 6 p.m. we need to give a sweet tea. At 7 p.m. At 7 a.m. we are feeding the patient, and then we are going for surgery. So based in cases of this fast track, when you're using this protocol, we need to feed the patient after surgery. In the evening. So, but in the evening, no one is going to feed you because no canteen is working at the hospital. So, of course, you cannot feed the patient after the surgery, But what about post-op? What else? What can we do? When should we feed the patient? I'm anesthesiologist, but I cannot give any, I would say, meal to a patient when I'm working in this resuscitation room. So what should I do? We are always trying to find indication. For example, if you want to go for antibiotics or for infusion, you need to have indication. But feeding requires no indication. It is very strange to ask question, who should be fed? Of course, the person who might face the problem with enteral feeding, of course, you will face no problem. This is the approach, the way you should go, because you will have all the patients who will be properly fed with your treatment. And if you will be always, looking for a reason why not to feed the patient. You will have no patients to be fed, really, because for everyone you will find the reason why you shouldn't do it. And in majority of national, I would say, guidelines, we have a lot of indications and a lot of, I would say, methods what to do. Of course, there's the calories, there's a protein, which helps us to increase the level of perfusion. And of course, it will help us to improve the blood flow in mesenteric artery, because we have no other pharmacological mechanisms for this. And the prophylactics prevention of translocation of flora, you know that the patients with hypoxia, there will be some systemic inflammation responses. So early treatment, early feeding is the best solution. So you have 24, 36, 48 hours in European clinical or American and Canadian recommendations. But anyway, you can see, if you will be trying to understand about the timing, it will be the first 24 hours. So I am telling you that you should not feed the patient overnight. Of course, next morning after the surgery, and we are checking whether there are some contraindications or not. For example, of course, we understand that each person needs protein, needs energy, but in our center, I guess we took the right path. We are having so-called electronic histories of disease, electronic anamnesis history. So easily each doctor can calculate the demand for food. So doctor will require at least 90 seconds to calculate the content, the balance between proteins, between fats, and the microelements, to have a clear idea what to do. And you can see the dynamics between what was before and what is after. And very important recommendation. There are so many mixtures. With what should we start? We should go for triad. There are three principal mixtures which you should use. It should be a standard mixture. It should be a standard mixture for patients with diabetes. These are with what we start. You do not have any specific mixtures for start point. And we're always using antibiotic therapy, antibacterial therapy. There should be a prebiotics or probiotics. This is not the main way to treat. This is the way to prevent antibiotic-associated diarrheas, which might lead to colitis. And talking about parenteral feeding, I would like to say just a couple of remarks that the major issue in case of parenteral feeding is incorrect or improper indications and administration. Therefore, in most of cases, we should not try to feed the patient, I would say, in improper manner. Therefore, we need to give, I would say, 3 days to the patient to try to, I would say, digest this enteral feeding. If the patient will fail, then there will be some alimentary insufficiency progressing. And talking about enteral and parenteral, we should give some parenteral treatment, in minor amounts, and in minor amounts enteral feeding, so the patient will receive the the target amount of calories. In Russian clinical recommendation, in clinical guidelines, they have very important table, very important graph is the criteria of the quality of assessment of the quality of medical, I mean the level of evidence and of course reliability. So the class of evidence, all of them are for 50 pages, and these page, I mean the 60 pages are fit in all of these 6 steps. If we will not match these 6 steps, nothing will produce the results. Thank you so much, dear colleagues, and it will be our pleasure to welcome you in the center of Almazo someday. Thank you so much for your interesting presentation. Unfortunately, you know, people are not paying attention on such important thing as alimentary status pre-op, and of course then it produces its negative impact in post-op consequences. And the very interesting question is that here at the area of former Soviet Union is that who is taking decision on early operational alimentation. In most of cases, in case talking about internal care unit, in most of cases it is surgeon who is taking this decision. But I think that it is surgeon who should take the decision in ICU. Well, I'm also the ICU specialist, but I think that it is 2 doctors consilium should be there. But anyway, I think that the opinion of surgeon is the most important. I'm of course dealing with these alimentations, though I'm working with the surgeons. I think that the surgeon knows more than me because he was the one who have conducted the surgery. But then, sir, you're absolutely right. We need to take the decision together. And as an anesthesiologist, I have been working even in emergency surgery unit and in scheduled surgery unit, but also decision should be taken pre-op, not post-op. And in most of cases, we have been managed the situation if we have started the surgery after surgery, we have been deciding about feeding and alimentation, then the things might create an issue. But anyway, we have a different understanding about this pathophysiology. I don't think that the surgeons will support you in commencing feeding the patient in as early as possible. And now we will be discussing about we will give the floor to Mr. Yuri Ligay. Correlation. Just dear colleagues, dear chair, it is my pleasure to be here to develop my presentation in front of you. It would be our pleasure to share our experience on the correlation between functional classes of heart failure and the microbiome. At the moment, as we have already shown you, this cardiovascular disease, that they are leading among the cases for mortality, and the reason behind this is ischemic heart disease as well as arterial diseases and cardiomyopathy, and all of them are related to heart failure or CKD. But anyway, we are well aware about etiology. We are well aware about any about etiologies, about classifications. We are satisfied with them. We know a lot about the treatment treatment of chronic heart disease. There are a lot of classes of medical drugs and pharmaceuticals, including even the heart transplantation. But do we have the patients who are not meeting the criteria for this surgery? Of course, we have such even patients, and it means that as time goes by, the patient's phenotype also may change, and it means that we need to find new methods of treating of heart disease. So the issue, what should be do? I mean, can the patient be fully satisfied with the treatment? We have noticed that the patients with such a disease is not just standard issues, but they also face some problems with gastric intestinal, or sometimes it might be vomiting, diarrhea, nausea, or even they might face coprostasis. So, of course, trying to find a solution, what is the reason behind this. We have identified a huge number of scientific articles and a number of hypotheses which are in effect all across the world, and there are two standard stages. First of all is modification and modified and non-modified factors, which we are very well aware even from our student times, and it's very important to keep in mind the microbiota, intestinal microbiota, which are closely related with such issues of course, obesity and insulin resistance. And we have started to learn microbiota since 2007, and since 2014, 2015, after the major project, human microbiome became popular all across the world, and it developed to its second stage. We have started understanding the importance of this issue. At the moment, we have so-called gut-heart axis, and which we will be discussing today. And in scientific literature, we have no information about correlation between microbiome and functional classes of the patients with heart failure. So you can see the criteria. They were quite simple for to be for assessment in our research, but the exclusion criteria were quite more complicated, which you have seen, including lung issues or major kidney disease or cardiomyopathy or severe chronic disease, including no probiotics and antibiotics within 3 months pre-assessment. And as a result, we have embraced 57 patients in our research, who we have managed to include since December 2022 to May 2023. And we had the patient with preserved outflow fraction, and also we have the patient with the higher functional class, and we have seen the patients with the higher functional class of 3 and 4 who had these gastric and intestinal complaints, which have been mentioned before. And you can see in dark green are representative of the second group of the higher class with the ischemic heart disease. And in most of cases, we had also hypertonic disease, and we could not identify, I would say, the evidence for this. And what is the portrait of this patient? The portfolio is that there was no difference between them in age or in, I would say, regurgitation, no change in glomerular filtration rate, but the issue was in proBNP and body weight mass and body weight index, and you can see that there were some external factors which could produce its adverse impact on intestinal microbiota, and of course we paid attention to the diet of the patient. So in this case the patients were feeling so-called data questionnaire, and we need to have this to calculate the nutrient consumed by the patient and having clearer idea of the number of or fiber containing products. And we have been measuring, I mean, the amount of food which patient was consuming in-house, and of course outside the house all the patients receive this standard medical therapy, and it has consent with European and Russian consensus as well as Russian cardiac disease. And you can see all the patients they have been consuming NGLT2 inhibitors, but the patients of the higher functional class, they had diuretics consumed, and of course they have been consuming euperium. And this is the Bristol stool chart, and the patient was supposed to come up with the samples of their stool, and we would be having this bacterial RNA, and each patient was measuring it and submitting the stool to our lab in our hospital, and then we have been keeping it in our special, I would say, storage in freezer in 20-25 degrees temperature. And then for RNA sequencing it was kept, and for the analysis in which class, and you can see that the difference between bacteria was statistically evident and reliable, and the patients with the higher functional class had the issues such a lack of bacteria which were emitting so-called short chain fertilizers, and we think that these bacteria are the most useful bacteria. And these patients of the second group, they had the bacteria which could emit trimethyl amine oxidase, which was facilitating progressing inflammation and the processes of cardiovascular failures. And at the moment we can easily tell that the difference between the functional class of microbiota is absolutely reliable and evident, and it has nothing to do with the gender or the age of the patient. And we will try to, of course, see more complicated statistical selections, and it is also related to the macronutrient diets, which is closely related to the filaments which are consumed. The microbiota is, I would say, new domain for studies, because we, at least as medical doctors, came up to the symptom of understanding, and we are moving from pharmaceutical treatment, we are going to so-called resynchronization devices. And even in cardiosurgery, we moved to the heart transplantation, but still we have still patients not responding to treatment. And what we had in the early 2000 or in 2010s, we should not, heavily intervene in the performance of human organism. We need to improve the alimentation. And I'm very happy that the previous report was some sort of a logical ground for my speech. And of course, it's not only relevant for the patient with cardiovascular disease, but also for the patients pre-op and post-op. Thank you so much for your kind attention. Thank you so much. Very interesting report, and it's very, I would say, delivered in timely manner. Yes. Do we have questions? Well, thank you so much once again. And now we would like to give the floor kidney preservation with Ringer's lactate solution or HTT solutions, please. Дамы и господа, уважаемый председатель, в первую очередь я хотел бы выразить свою искреннюю благодарность по двум причинам. В первую очередь это по случаю 50-летнего юбилея центра Вахидова и, конечно же, за это замечательное событие, за это замечательное мероприятие, которое у нас сегодня проводится. Теперь, когда мы будем говорить с вами именно о растворах, лактозных растворах Рингера или же все-таки о других вариантах. То есть как нам быть, да? Конечно же, очень важно это ишемия. То есть ишемия, она может быть связана с ишемическими ситуациями. Также это может быть и трансплантация от живого донора. И, конечно же, эта трансплантация, это уже от посмертного донора. То есть, конечно же, для меня очень важно начать, наверное, пожалуй, поговорить именно по торакальной хирургии, по торакоабдоминальной хирургии. Вы знаете, были такие исследования, это последнее исследование, которое было опубликовано в журнале грудной и сердечно-сосудистой хирургии. И вот здесь очень важный этот вопрос рассматривался, то есть именно сопоставление раствора Рингера и раствора гистазин, триптофана, кетоглутарата. И, конечно же, мы понимаем, что действительно обычно вот этот гистазин ГТК, он давался только вот именно в период именно ишемии, а после чего... Я прошу прощения, также это тогда, как именно раствор, именно лактозный Рингера, он давался именно непрерывно. Вот в этом большое отличие состоит. И вы знаете, вот видите, вот здесь два у вас есть раствора, то есть раствор ГТК и раствор Рингера. И посмотрите, знаете, самый основной момент, самое основное важное, скажем так, отличие состояло в том, что раствор ГТК все-таки это гистидин или аминокислота, то есть это раствор аминокислоты, то есть здесь нету буфера, понимаете, да? Вот этого буфера нету в растворе Рингера. И теперь давайте, если мы все-таки будем сопоставлять результаты, клинические результаты, и вот именно вот это у нас почечная ишемия, она была все-таки, здесь у нас было сопоставление 44 против 36 против 41 в группе ГТК. И касательно, когда мы говорим о именно почечной недостаточности, вне зависимости от того, это первая или вторая группа, все равно разница существенная в результатах, которые связаны именно с методом защиты. И теперь мы, конечно, мы видим сейчас вот острую почечную недостаточность, идет оценка ее, да, то есть это по степеням 1, 2, 3. И, конечно же, мы видим с вами в частности, и что здесь идет и креатинин, сыворотка, да, и мы видим разницу именно между ГТК и, в частности, и раствором Ренера. И в частности, здесь мы видим это первая, вторая или третья часть, в зависимости от того, какой раствор сейчас у нас применяется. И теперь, когда мы говорим, именно связано также это и со скоростью глубокой фильтрации, и это не всегда, конечно, значительно, но в целом это будет превосходить именно в группу именно гистидин, триптофана и кетоглутарата. То есть мы видим также и параметры уже послеоперационные, которые существенно различаются. В частности, мы видим, что если у нас здесь нету острых проблем, именно острые, я бы сказала, почечной недостаточности в группе ГТК, они все еще остаются в реанимации, там, конечно, больше, то есть срок нахождения в реанимации, да, и, конечно же, мы еще один момент, что происходит в случае трансплантации печени, да, донора. Мы начинаем, это вот есть исследование индийское, которое именно мы сопоставляли, опять-таки, Рингера, раствор с ГТК, и посмотрите, здесь ишемия дольше продолжается именно в группе ГТК, тогда как она была замечена покороче, ишемия именно в группе раствора Рингера. И тут мы также смотрели и на уровень средний именно уровень, да, креатина, и мы видим, что в группе ГТК он был выше, особенно с 1 по 3 день уже после операции. И теперь, когда мы с вами смотрим на еще одно исследование, которое сопоставляли именно растворы, то есть действительно это мы сопоставляли здесь растворы ГТК и сопоставляли это и с другими растворами, и в частности мы видели действительно, что вот этот раствор был более эффективным, раствор Бельзера, да, и мы видим, что действительно спустя много лет назад вот это вот раствор университета Висконсина, да, как вот они тоже его сопоставляли с ГТК, и вот мы видим здесь какой результат, да, то есть здесь уровень именно приживаемости трансплантата и в целом уровень выживаемости, потому что, кстати, по мере хода времени вот здесь становится очевидным, что я прошу прощения, что в ГТК у нас более наблюдаются высокие результаты по сравнению, именно в части уровня выживаемости за год. Я имею в виду даже по сравнению с раствором Евроколлинса, и действительно мы видим, хоть и данные не были даже и статистически значимыми, и все же, если мы дальше будем смотреть на уровень приживаемости трансплантата в случае с растворами университета Висконсина и ГТК, мы видим, что ГТК все-таки превышает и раствор Евроколлинса, и по эффективности и раствор университета Висконсина. Какой вывод мы можем сделать? В первую очередь, что результаты сомнительных исследований по защите почек именно между ГТК и раствором Рингера, это становится очень важно, поскольку сколько это связано в первую очередь с причинами ишемии почек. Второе, это важно, что более короткое время ишемии почек, оно все-таки менее продолжительное, да, то есть будь то это, если трансплантация от живого или же от умершего донора, это, то есть существенных качественных различий не было выявлено по части защиты именно при помощи раствора Рингера или же ГТК. И касательно, если у нас действительно, если, допустим, было использовано лоскуты от умершего донора или были долгие периоды теплой, холодной ишемии, когда использовались растворы ГТК или же университета Висконсина, мы видим, что результаты результаты ГСК были намного выше по сравнению с другими препаратами, которые давали более долгосрочную выживаемость, и, соответственно, ГТК больше используется как стандарт при использовании при евротрансплантации. Спасибо большое, уважаемые коллеги, за внимание. Да, большое спасибо действительно за вашу интересную презентацию. Она действительно очень важна. И, коллеги, если у нас есть вопросы, вы знаете, это все-таки, наверное, зависит от того, насколько вот идет время, да, холодной ишемии. Это все-таки больше с этим связано. То есть результаты зависят от времени ишемии. То есть, смотрите, чем короче ишемия, тем лучше. Да, я с вами полностью согласен. То есть, вы знаете, статистических результатов значимых вы, может быть, сразу и не выявите, если время ишемии очень короткое. Но чем больше время ишемии, тем больше результаты уже проявляются. Скажите, а вы какой используете при фузии используете? Вы знаете, я улыбаюсь, но почему? Потому что, вы знаете, я в первую очередь, я вначале был физиологом, да, и, вы знаете, я сам начала разрабатывать сам растворы, и только потом же я стала врачом, да, вы знаете, я, конечно, представления не имею о технике лечения перфузиями. Спасибо. And now we would like to give the floor to the syndrome of low cardiac emission on the background of diastolic dysfunction of LV in cardiosurgery. Dear colleagues, first of all, I'm thankful for inviting me to deliver speech at this reputed event, standing here in front of you. And well, I will try to embrace this issue within these 10 minutes. There are two issues which can be discussed here, and all of these issues are very important. Of course, we will try to highlight the major one. We cannot highlight everything, but anyway, talking about the chronic kidney disease, it is not me who should tell you about this. I guess everyone knows, and especially cardiologists are very well aware about this. And talking about hospitalization, and of course, I can tell you that the majority of these patients, they have a very nice function of emission from left ventricular, and I can tell you that everyone should be, well aware that we will be meeting these patients, and the patients still have some sort of diastolic dysfunction everywhere they will be, and this is the picture from our article. And if you might be interested, it will be our pleasure to share it. I will show you my email also in the last part of my presentation. And now let us remind about pathophysiology. You know that the heart cycle is composed of 6 stages, and you can see that there are period of, systole and diastole. So systole is of 2 stages, and diastole is of 4 stages. And you can see how it goes. And talking about the heart cycle, from the point of view of the processes which are taking place over there, one of them are very proactive processes, constriction, and then of course relax, and we should look at this scheme, and you can see at the systole phase, at the relaxed stage, the processes are starting in myocard, and my experienced colleagues are very well aware, and that we had so-called the stone heart phenomenon, and it was the severe stage of ischemic lesion when the heart was stopping, ceasing at this systole rate, and it couldn't simply relax. And now, of course, talking about these diastole processes, of course, we should also keep in mind that there might be some problems, and of course, ischemia, myocardial severity, and the tachycardia, all of them are there, and diastolic dysfunction significantly differs from systolic dysfunction, and you can see that we have shown here the blood pressure and the volume, I mean the relations on systolic and I mean in healthy heart and in systolic dysfunction, and of course we can see that the ventricular are just relaxing. So we should also keep in mind that that it will at least brings the higher risk of lungs edema, and so here we have the healthy myocard, and over there we have unhealthy myocard. So, of course, we need to, I mean, find, because we see the different volumes, that is the issue. And if we will be striving to find some equivalent solution, I mean, in systolic solution, we will find a high, I would say, risk of lung edema, and the safe corridor for the patient with the systolic dysfunction. It is it is not easy actually to deal with this volumetric therapy, because there might be edema, or patients are facing this cardiogenic shock. So we need to find a solution for this, and in case of diagnostic of this diastolic dysfunction, of course it is based on cardiological criteria, and we have the deadlines which we have, and these deadlines are clearly showing us that of course they do not meet the required, and they are not appropriate with the patients in post-op, and they are not meeting to the patients with problems with their valves. So this is our research. This is a retrospective analysis of 220 patients, which we have divided into two groups: the patient with clearly expressed lesions of myocard, and the patients with the unclearly express myocard, and of course we have the troponin, and of course it has the higher risk of mortality. And if you will look at the diastolic dysfunction, I mean for second and third grade, the patient, I mean there's no difference, there were no difference between the patient, and you can see that the patient with myocard lesions
and of course they were patient, and so I mean the patients were not meeting certain criteria, and of course it means that the diastolic dysfunction might, in our opinions, be one of the criteria of peri-operational issues with myocard lesions, which we do not pay proper attention to. And talking about the strategy of decision making and the therapeutical strategy for the patient with diastolic dysfunction, this is some sort of the pyramid where the key issues have been specified. Of course, there should be a disease, for example, the patients with diastolic dysfunctions are normalizing the heart constriction frequency, and you know that in most of cases it might sometimes disappear. And of course I can tell you about these 2 days, I mean the cardiac days, and look at this. And the next stage, the second stage, we are now trying to normalize the hemodynamics and artificial lungs ventilation, and we can differentiate also the violations in the intensity of Mankand. You can see that noradrenaline here, but anyway you will have the clinical data, and you can use also the mechanical instruments. And as our patient has been stabilized hemodynamically, we can resolve this issue. And well, there might be a clinical syndromes, and there might be things which might produce adverse impact on our patient, because each of our patients are reacting differently to what we have. I am very thankful for your kind attention. And actually, thank you so much for your very interesting report. If you have any questions, please. I guess everyone is discussing it in couloirs. But anyway, I guess it will be our last report before the lunch break. And yes, the learning and teaching the state-of-the-art surgery methods on TME. Mr. Karachun, please, floor is yours. Dear Chair, my dear colleagues, I will also join all the congratulatory remarks to the event, or to this event, and I'm very happy because in Uzbekistan I have taken the decision to become surgeon. I am from the research institute named after Petrov, and we have heard a lot of researches on surgeries, and I will try to be very fast. And I can tell you that we are dealing with tumors, I mean open accept laparoscopic robot assisted surgeries
in all of these things, and of course we are promoting this robotic surgery, so I came up with the report on how to we do it. So I decided not that I will come with the report, I will now present you the report which I have presented since 2015 in one Portuguese clinic, and 10 years have passed away, and this I would say approach helped us to come all the way along when you are trying to introduce new technologies. I'm pretty sure that it will pay off because we have obtained very nice results. Here, you see, I see the report, but I'm not sure whether can you see the report. Probably some technical issue. I understand that everyone is rushing to enjoy delicious Uzbek pilaf, and actually I'm also ready to start, but I do not know how to fix this technical issue. So talking about this trick, what is TME? It's a total mesorectomy, and now talking about this report, we have been learning about whether this laparoscopic surgery become a standard of treatment, or will it be some sort of just a fashionable trend. So we have not been quite aware. So and the results, when we have just kick-started, we're not producing something new. But of course, there were no changes in mortality rate, and the long-term results could not be, of course, easily identified because we had very short period of, I would say, follow-up. So in 2009, we had no surgeries on laparoscopic surgery of rectum, and since 2014, we have started. We had already significant increase. And what was the thing we have achieved? It's not what was the thing, but how this thing has been achieved. So we will be discussing this now. Well, our plan was quite simple. We have been set up with the task to start with laparoscopy. Everyone was well aware what laparoscopy is. So let's not waste time. Let's simply jump on it. And the Ministry of Health of UK came up with the instructions that each clinic which deals with the cancer of colon should give the option to the patient for laparoscopy and open access. I would say, very severe decision. It is not easy to take it in Uzbekistan, of course, but or in Russia, but the UK developed the centers and even the national program for nurturing surgical personnel. They have engaged the experts from all over the world, and in a very short period of time, surgeons from Great Britain learned how to handle this technology, and even they have become leaders in promoting it. So in the beginning of 2020, majority of surgeons were from here. We were thinking that this is the same thing, but you know that the wet lab is expensive, dry lab is too expensive, and whatever is available, whatever is cheap, is our patients, and we are using them as training, I would say, objects. We have YouTube, you have a lot of professional stages. Look at how this bicycle is, he is driving the bicycle. Look, it looks quite easy. Everyone will say, oh, come on, give me a nice bicycle and I will do it. But look at what we are doing with laparoscopy surgery of rectum. It's not quite easy. I mean, everyone knows what rectum is. If you will have a nice tools, we will deliver nice results. We have been quite sure that we will come up with nice results. We have tools, we have everything, but we are not doing anything nice. We are not coming to nice results. We cannot understand the reason behind our failure, and this is our surgery, the first surgery of TMA, which I was very happy when I placed it on my channel of YouTube. Now I can tell you there's nothing to be proud of. This is a demonstration of the way how you should not conduct the surgery. And you need to find some other methods because our plan definitely differs from the reality which we come across in real life. So the key issue is that we cannot do it because we cannot move our fingers the way experts or professionals do. Of course, because we cannot understand why he is doing this way, why he is not acting in other way. So if you will be, for example, riding a bicycle, and if it will be some sort of role model for you, so for you to overcome certain obstacles, you need to have, I would say, some ramp. So for us also to start with less invasive technologies, you need to have the concept. And we have found this concept in Portsmouth Hospital, and my teacher, Professor Amjad Pavais, is here, and the Professor Danila Miskovich, Jim Hunt, and Tashka Veshi, and we, our delegation from Russia came, and we have been puzzled with the technology, how the surgery was made. I mean, it is white surgery with no single drop of blood. And of course, how we have been doing, it's a teamwork. You know, it's not just words. Everything you can do it in open access surgery. You cannot do it. I mean, it's illegal. But in surgery, your success in the hand of cameraman. So if your team is not helping you, you will not come to result. And we have sent all of our team to Professor Amjad Pais so that he would treat everyone, so they will see with their own eyes. They should not see on how the surgeon is working. Look at how nurse is working. Look at how cameraman is working. And I was thinking, oh, come on, I'm the leader. I will be the one who will be leading the team. At least I was thinking that I'm a leader. And I will be the one who will be, I would say, managing the ride. But look how the bicycle team is going. The first one who is, I would say, resisting the flow of wind, he becomes the leader, and he gives the chance to the other colleagues to have a rest. So, I mean, the cameraman was becoming a surgeon, the surgeon was becoming cameraman, and we could understood that we cannot, easily resolve this issue because it is not easy to show properly the image on camera to the surgeon. And as we have started changing our roles, we have understood the situation. Please pay your attention. We have one lazy man and one leader. Yes, and the technical assistance. If you do not have a technical team, you will never be able to accomplish something serious. If you want to get milk, you should not buy milk. You should grow a cow. So the cow will deliver you a milk. And therefore, you need to have a system at pre-op, the surgery, and of course, post-op. So it's not just a tool. Of course, I will not be focused on this, but anyway, you need to deliver the performance of the team by creating it, and you need to learn on regular basis. If you do not have a mentor with you on regular basis, we have been filming this video. We have been sending to our professors, Mr. Amjad and to Mr. Danila, who have been 3,000 miles away, and they have been giving us the idea where was our mistake, when we have conducted this mistake, at which minute of the surgery, and we have been improving the results. And you can see the techniques which we have been doing. This is laparoscopic resection of the rectum. I will not explain these things. I guess everyone is understanding, but anyway, you can see everything, and we came to a certain result. So what? It became better, it became worse, or it became more beautiful. So here even you have so-called the photo finish. So even here you also need to have it in the surgery. So without no idea about, I would say, your results, you will not move further. So these three persons riding the same bicycle, it should be in each of the teams which are dealing with the rectum surgery. Of course, he should be the specialist in MRI. If he made a wrong assessment of the stage of the cancer tumor, of course, it will lead us nowhere. It will mislead. And of course, number two is our surgeons, the one who will be giving, say, I would say, who will be accountable to the patient and to the patient's family. And this smiling girl is morphologue. She knows the right situations. She knows the truth. And she will be the one who will be independently assessing your results. I will not comment this table of 10 years old research data, but anyway, I will not jump into criteria. I just can tell you that we have received quite clear data, fair data, that, I mean, what the person are doing if they do not know how to do. They are teaching us we are calling them the comedian surgeons. So we have called Mr. Antonello Forgione. So he was the first master class conducted by him in our institute. And in 2013, we had two conferences conducted in April and in November, and video surgeries and lectures and translation into Russian are available at my website and at the website of our institute. And in 2014, we had a master class for Russian surgeons. And in 2014, we had TMA performed by our team. And all of this helped us, I mean, from 0 to 68%. And I would like to inform that it is very important that this process of teaching somebody to something, it's a bilateral thing. I guess that the person who is coming to you and whom you are trying to explain, he will share his opinion. And so this is the best way, actually, this is the most efficient way to learn something, is to start learning. And let me end with the quote of Winston Churchill. It's move from one failure to the other without losing any enthusiasm. Winston Churchill. So thank you so much for very interesting presentation. And unfortunately, indeed, we are not paying sufficient enough of time to the treatment and the teaching methodologies. Colleagues, please, in case of any question, because they are very important for the success of all the surgery team. Do you have any programs which have already been approved based on your recommendation, based on your experience? No, we do not have it as yet. And that is our problem. We have the huge department on professional training. We have a lot of, I would say, even trainees from Uzbekistan. They're coming to surgery. They're looking at what we are doing, and we are explaining them. That is the way it goes. But it's interesting to those who would like to learn, rather, but without any person who is originator, who is ready to initiate, nothing will move. That is the issue for all the former Soviet Union countries. We do not have the, I would say, unified approaches for treatment and for training. So everyone should learn, I would say, in accordance with the standards, and it would be the best, I guess. But in each country, they have different protocols. Nothing is harmonized and unified. That is the issue. Thank you so much. And upon your kind permission, now we would like to invite all of our guests to Azovsbek restaurant, 300 meters away from here. Please kindly let us go for pilaf.